Good morning, everybody. My name is Michael Sook. I'm the chair of the Musculoskeletal Institute at Geisinger Health System and also the chief physician officer for System Services. And it brings me once again great pleasure to open up the 13th annual John Parenti Lectureship in Limb Salvage. This has been kind of a labor of love for us. I started actually in 2012 when they had actually done their first one. And so I've been part of this event for now 12 years. But this is really in honor of a gentleman who's been an icon within the Department of Orthopedic Surgery and also the Musculoskeletal Institute, certainly an inspiration to me. He's somebody that we have, I was telling this story yesterday, it's oftentimes very hard for someone to come in as a new chair when the old chair is sitting there. Right? And so in some cases that can be made very difficult, but John certainly always made me feel welcome and help support the department to the point where we couldn't, even though he wanted to retire 10 years before he actually did, we wouldn't let him go because of his contributions and his desire to not only help teach residents, but also help keep the clinical service alive. And so with that, I just wanted to just recognize John, if you don't mind standing up, and in case people haven't seen you or met you before. John is retired now in one of his multiple locations, but more recently in Florida, and thankfully they made it through the hurricane okay. But he's come up just for this particular event for us, and so really great to see you again. I also want to recognize our benefactors for this meeting, and we're going to learn a lot more about Arturo and Nina Porzinkansky, who through a generous foundation grant were able to help support this event. And they are actually all on there. Unfortunately, unable to be here today. This is the first one they've missed. They've had to stay back in New York, but I know they send their greetings, their warm greetings to all of us. We are live streaming this event, and so I know that they're listening, and I'm sure they're giving a wave at this point, but I certainly want to recognize John and Nina. John and Nina, we just got notice there's 12,000 people on the web stream currently. No, I'm just kidding. But I haven't gotten that note yet, but I'm sure that there are many, many people who are streaming in for this particular event. I want to also thank the medical school. This is the second time we've done it here. If you look back at our journey on the Parenti conference, we've been everywhere. We actually did this one time in Philadelphia. Have done it in Danville. I've done it in a number of different cities. But I think now we decided yesterday that this really feels like more like a home for us, and so we hope to continue it. We're planning it again here for next year. Dr. Byerly, our dean, has been generously supportive of our efforts, and the medical school and the students are taking a greater interest in doing this. Also want to thank all of you for coming this morning. I'm looking in the audience. There's some people I haven't seen since the pandemic, I think, in some cases, but it's great to see you all. The great representation from MSK to really get involved with some really cutting-edge conversations around what's happening in MSK. Everyone's talking about AI, and we have some homegrown experts within Geisinger that are really nationally known for what they're doing, and I think it's going to be a very interesting and wonderful conference for us to go on. I'm going to pass the baton to Katja Zinzer, who is our Chief of Podiatry in Central Region. She and Nicole Branning both co-chaired this event, and I think, thankfully for me and many others, this is a labor of love for them, and they spent the better part of a year trying to plan this, make sure that this comes off without a hitch. Katja, as many of you know, has been with us about 10 years, has been in the Central Region, and most recently promoted to the Chief of the Central Region for Podiatry. Has done a fantastic job. Very passionate, as all of you knew, from Peru, and has done a number of things really inside and outside of Geisinger. I think we're very, very proud of. Great teacher, graduate of Temple Podiatry School, and also did her residency there, and then came and joined us in the Central Region. So, Katja, I'm going to turn it over to you to kick us off on the festivities here. Thanks, guys.
Good morning, everybody. I echo the welcome for everybody who is here live and for those who are live streaming, especially, our greatest thanks to both Arturo, our benefactor for this, and Nina. We do wish you the best in recovery, and we are very excited that we are able to use technology, which we'll be talking about today, to live stream and really have you here. I did check in with Arturo just a couple minutes before we started, and, they've got the morning popcorn, and they are ready and watching and excited to learn and hear what we have. So again, I think a round of applause also in recognition of Dr. John Parenti, who we are here to understand the story and see the path of where we were and where we're going. So, when we talk about this lectureship, the onus really on us as the committee and, structuring these sessions is a platform of education. And so, though we have it listed as a limb salvage conference, we look at what we are getting and garnering from an education lens and how we're paying that forward. So when Arturo talked to us about what the focus, he wanted to make sure that this was something that was left as a legacy, and a legacy to Dr. Parenti for the 40-plus years that he invested in, his patient care and his outside-of-the-box thinking. And so a forever learner, and I think for most of you who are sitting here today, you are forever learners, and I hope that you continue to pay that. So when we looked at what would we have for this year's event, it was, not with a lot of options, but looking at how could we promote what happens before we get to that discussion about limb salvage. And so the question to me was, why or how? How can we do that, and what tools do we have available? So it came to kind of like an unfolding of what if we had known what we didn't know about capillary leak syndrome. And, thankfully for Dr. Parenti, who was the third or fourth consultation for our donor, which you'll hear the story, and I am gonna warn you, have a Kleenex, or if you don't have waterproof mascara for the ladies. It is heart-wrenching, and to be able to see it come full circle, but to be able to have somebody who was innovative and thought, steps ahead on limb salvage, that is why we have this lectureship. So looking at this, the musculoskeletal care in the digital age, the informatics, the EHR, and looking at the optimization and the artificial intelligent optimization, some of you might be there kind of scratching your heads like, what's this have to do with limb salvage? It has everything to do with really any chronic disease that we're dealing with, and then the end result of possibly having, a loss of a limb. So when I look at what and why, I think of, the why do we do this? Why do we constantly learn? Why do we put on programs like this? And for many of you, I guess I want to see a show of hands. How many of you know the author and surgeon, Atul Gawande? Okay. Yes, every year it's a little bit more. So this is a quote from him from Better. He says, "Better is possible. It does not take genius, it takes diligence. It takes moral clarity. It takes ingenuity. And above all, it takes a willingness to try." So as you sit here, I want you to think of how you play a role in that ingenuity, how you play a role in being innovative with the tools that you have in front of you, with the patient that you have that's difficult, that nobody else was able to find an answer. Think like Dr. Parenti, think like others who have come before, and then be able to kind of put your lens on how we are gathering information and how we're better able to use it. So the speakers that we have today are powerhouses. They come to us from inside, from Geisinger. I'm proud to say that they are part of our Geisinger family. A lot of times we bring external speakers which have been phenomenal, national and international. We went back to our roots, and really the donor was very excited. He's an economist from Wall Street and was thrilled to find out that we had our powerhouses, no pressure guys, here at Geisinger. So, I want to do a little kind of brief bio overview. Our keynote speaker, Dr. Levy, if you want to just kind of take a stand, Dr. Levy, you will see him. He is our keynote speaker. He's a graduate of, that little place called MIT. New York College of Medicine. He's also the Associate Chief Medical Officer of Informatics. He does run the Informatics program, and we do have that fellowship program. It is renowned as one of the best, if not the best, fellowship program in informatics in the country. We also have Dr. Jeffries. He is here today. He's one of the Associate Medical Directors for the Artificial Intelligence at Geisinger. He also is a neurohospitalist, and he has half and half with the research as well as the clinicals. Extremely busy and bringing us some of the AI and the implementation of what he has done with a lot of the programs through Epic. And then we have Dr. Dang, who received her DO and PhD, a medical scientist from Michigan State University, and she is out of the Dickey Clinic in internal medicine and also bringing us a lot of the informatics and that Epic utilization. And so, we've got a little bit of everything. And if you know Epic, we know that it is more like an artichoke, I call it. We've got layers upon layers. So I hope this kind of unveils some of the layers that you can use, and we want to make sure that there are pearls that you take home with you to be able to use in your practice. Before I start off with our video, I want to make sure we're doing a couple of housekeeping. This is a pretty robust schedule that you see on your agenda. We're hoping that you can kind of either jot some of the notes that you have or questions, and we're going to hold it off at the very end. We're going to have a panel. All questions are going to be asked, answered. There'll be mics on the floors here, and we can kind of go through the flow with this. We will have a break set up at 10:15, and we are going to kick this off with our video presentation and sit back and just absorb the history of where we were and where we're going, and listen to the role that Dr. Parenti played in somebody's life, Arturo Porzecanski, and how big of a role that was and why we're here today. Thank you.
My name is Arturo Porzecanski, and this is my story. The story begins in November of 2005, during Thanksgiving week, when, unbeknown to the Geisinger ER and ICU physicians, and to me, I was admitted in a state of life-threatening hypovolemic shock because I was experiencing the first episode of a rare disease called systemic capillary leak syndrome, or SCLS, which features the transient separation of endothelial cells in the capillaries of the extremities, leading to the extravasation of most of one's plasma into surrounding tissues and muscle compartments. These episodic leaks of plasma do not necessarily cause permanent damage to arms and legs. The leaks cause compartment syndrome, especially when, in an understandable attempt to keep vital organs duly perfused, ER or ICU physicians engage in massive fluid resuscitation, which is what they did to me. Once we're properly diagnosed, ER and ICU physicians know that, should we experience an episode of SCLS, they ought to minimize the administration of fluids to prevent massive leaks and further muscle and nerve damage, while having orthopedics monitor our muscle compartments in case preventive surgery in the form of fasciotomies becomes necessary. Given the extent of the damage, the surgical team on duty was initially uniformly pessimistic about the chances of salvaging my lower legs, so they recommended their amputation. I was deemed too vulnerable to infection, accidental loss of circulation to the feet, and other complications and negative outcomes of limb salvage in the wake of so much destruction. They could not conceive that I would be left with functional legs and feet that I could use to walk on, whereas an amputation and modern prosthetics, like the carbon fiber blades that the South African runner Oscar Pistorius made famous, had proven to be effective in the restoration of almost normal function. The next thing that happened was that my family and I refused to grant consent for the amputations, especially on advice from my brother-in-law, then a senior Geisinger vascular surgeon. Because my episode of SCLS had concluded, my general clinical picture improved rapidly. Moreover, there were pulses in my feet, indicating sufficient blood circulation to them, and I was relatively young and otherwise very healthy. There was thus no urgency to proceed with a preemptive amputation. The challenge, however, was to persuade at least one Geisinger surgeon to commit to the salvage and preservation of my limbs. Dr. John Parenti, at the time chief of orthopedics, then joined the team.
I had been on a vacation and was not here at the hospital for probably an entire week. But during that time, Arturo had been brought to Geisinger via life flight in serious condition and ended up in our ICU. When I first met him that Monday morning, though, it was in a regular clinic room since he had improved dramatically over the few days that he was here, and I was meeting him to discuss further surgery.
And to make a long story short, we succeeded in persuading him that I had a good chance of surviving the many operations that would be needed over several weeks to remove all necrotic tissues.
The uniqueness of this case is the fact that throughout his surgical procedures, numbering at least 6 and probably more, I had to remove every muscle from his lower extremity, from his knee to his ankle. I had never done that previously, nor have I ever done that since.
To be sure, neither he nor us knew to what extent I would be able to walk again and go back to work, since no muscles or nerves survived below either knee, and both my feet were immobile and insensate. The most likely scenario was that I would end up in a wheelchair, so much so that I went shopping for a motorized scooter. But something told me not to buy it. I checked myself into an inpatient facility for several weeks and put a lot of effort into physical and occupational therapy, followed by still more weeks of outpatient rehabilitation following my return home.
I was amazingly surprised to see Arturo back on his feet when he first returned to our outpatient clinic. Having undergone such incredible surgeries, both in number and in extent, I really didn't think I would be seeing him walk into clinic. I was very surprised to see this. I definitely expected him to be in a wheelchair at that time, and he thoroughly surprised me. To this date, Arturo's feet have held up remarkably well. His extreme vigilance in taking care of his feet is remarkable. I've not noticed any breakdown of his skin, any calluses, any open wounds or ulcerations, despite the fact that he has no sensation in his feet, nor any movement at his ankles or toes.
My wife and I decided to endow the John Parenti Orthopedic Education Fund for 2 reasons. First, we wanted to recognize Dr. Parenti for his lifelong dedication to patients with challenging orthopedic and wound healing problems, and to pay homage to his personal courage in this specific instance, in which he took on and persevered with a high-risk case, demonstrating excellent surgical and post-surgical skills, and showing compassion for and confidence in his patient. And I'm referring to me, of course. Second, because we wanted to change the mindset of the orthopedic department by sponsoring a lectureship series that would bring renowned speakers from around the country to talk about the latest developments in the field of limb salvage and preservation.
We operate on patients, we don't operate on x-rays, we don't operate on lab results. We have to see the patient's needs and to listen to what they want if truly their decision is not totally so bizarre that it's not in their best interest. Arturo was an amazing patient. He was a healthy gentleman. He came here without comorbidities. It was safe to take him back to the operating room to do multiple operations. And thus, I feel the takeaway here is the fact that we were able to listen to his wish not to amputate. And then, even though it was time-consuming and maybe not most expedient, we took him back to the operating room and did numerous repeat debridement procedures over and over in order to salvage his extremities, which is what he wanted, and he's extremely pleased with this.
The fact is, surgeons usually don't have to deal with the serious physical, psychological, and financial consequences that follow from limb amputation. Therefore, what looks like a successful outcome to a surgeon is sometimes not viewed as a successful outcome by patients and their families. This is a perception gap we want to see closed.
It's incredible. I've seen this video numerous times, and every time I see it, I catch a little bit more. And to see the passion and how Arturo speaks about knowing that there was somebody out there who could have the answer, and he was willing to meet them and work through. So again, thank you, Dr. Parenti, for the innovation and for the heart for the patient. Without further ado, I want to bring to the stage Dr. Levy. He is our keynote speaker today, speaking on bridging the gap on data literacy. And again, I want you to have the lens on how we can use this information to really prevent some of the devastating outcomes that we see. The statistics there are even higher in many areas. So I would like to present Dr. Levy to the podium.
Good morning, everybody. So, as you've heard, I'm Bruce Levy. It's great to be here. I'm just very honored. I got to meet John last night. We had a really great dinner, a great conversation. I'm sorry that Arturo and Nina, you couldn't make it. Best wishes to both of you, and my gratitude to you for putting this program together for the last 13 years. So I'm here to talk about informatics, bridging the gap on data literacy. And what I'm going to do in the time I have with you this morning is kind of talk a little bit about how we got to where we are today, give you some examples in orthopedics, and then lead you through the journey we've been taking within clinical informatics to bring this concept of data literacy really to the forefront at Geisinger and kind of leading the pack of what's going on around health systems around the country. We all accept that change in medicine is going to happen, and that it's mostly good. But I don't know if you've noticed this, but in the 40 years that I've been in medicine, it seems like that rate of change keeps accelerating over and over again. And for some of us, people like me, this change has an exhilaration to it. You feel the excitement of the change that's happening. But for many others, this is very frightening and anxiety-provoking. We don't know what our futures are going to be. We don't know where all this is going to lead. And that's very important to understand. Clinical informatics is essentially the science of health data. We're going to discuss informatics this morning, EHR, and EHR efficiency. We're going to talk about big data. We're going to talk about AI. And we're going to hopefully learn this morning how we can increasingly in the future use informatics to help make medicine better than it has been for the benefit of not only our patients, but for all of us who are working within medicine. This is a really long story, longer than most of you probably are aware of. As long as there have been computers, going back to the post-World War II era, there have been discussions about how computers will impact medicine. This is actually an article from the New England Journal of Medicine from 1970 about healthcare, computers, and change. And it made some interesting predictions about the 21st century. Some of these predictions were eeringly prescient, like computers will actually monitor physician performance. We're very familiar with that. We get a lot of data about ourselves, and sometimes we like it and sometimes we don't. And then there are newer things that he talked about in this article, about computers listening to doctors and patients and helping to guide the care. And what are we doing right now? We're starting ambient listening, where an AI will listen to the visit between a doctor and a patient and generate the note for the physician. Very exciting stuff that is going on. What I thought was really interesting is in the article, Dr. Schwartz, who wrote this, believed that the computer will help free the physician to concentrate on tasks that are uniquely human, such as the application of bedside skills, the management of the emotional aspects of disease, and the exercise of good judgment in the non-quantifiable areas of clinical care. This is 54 years ago, and what I would say is today we are still striving for this vision that Dr. Schwartz expressed back in 1970. Let's take a look at orthopedics for a minute and how far things have come for all of you. This article shows the adoption of orthopedics implementing EHRs. And if you'll look, back in 2011, not many years ago, only 8% of orthopedic practices were using an electronic health record. And it was only 8 years ago, in 2016, that orthopedics finally broke that 50% barrier. Think of how far we have come in those past 8 years, where 8 years ago, half of you didn't even have an EHR at all. The change is just staggering. Today, we talk about AI in orthopedics, AI across medicine. This is a 2023 paper. Bagheri et al. Describe how AI and machine learning have had positive impacts on diagnosing and treating patients with chronic limb-threatening ischemia, even though AI is still in its infancy. So using AI, in this article, and this is a review article, they talked about a lot of other papers where they had used AI to help better diagnose chronic limb-threatening ischemia, how to better prioritize, triage, and develop better treatments for it as well. And as the authors here said, this is amazing because AI is in its infancy. Where are we going to be just a few years from now? Another article through the military was able to use artificial neural networks to accurately estimate the likelihood of amputation in cases of open calcaneus fractures. A result that turned out to be 30% more accurate than the previous processes that had been used. So these improvements that AI are bringing to the practice of medicine are real and have great impact upon our patients and our ability to help them. I hope we can all agree, just like a lot of technology, I think you've heard of the hype cycle. We are definitely riding the AI hype cycle right now, and we're early on our journey. Everyone's talking about AI. It's either evolutionary, it's revolutionary, or maybe it's the beginning of the end. But there have been an explosion of generative AI tools and applications for our use. Geisinger is among many systems currently using AI in the workplace. And in fact, many of the images in my presentation, including this one, were generated using DALL-E 3, an AI imaging engine within Microsoft Copilot, which, by the way, is available to all of us at Geisinger through Microsoft Edge. It's really easy to use, and it's a lot of fun. You get pretty interesting looking images. We're launching ambient listening, as I said, with AI to create patient notes. And in the broader sense, new AI companies are being formed at an incredible rate. And we're seeing a proliferation of AI tools out there. But remember, this is the hype cycle. And this is actually a very recent article, September 23rd in the New York Times, Will AI Be a Bust? A Wall Street skeptic rings the alarm. And this is an article by the head of stock research at Goldman Sachs. And he's concerned because he gives an example. And in his example, his analysts who would previously do research on companies that they're researching as part of their investment strategies, they would actually have to transcribe the information about the companies they were working on manually. Now AI can do that for them, saving them 20 minutes of time per company that they're researching. The trick? The AI actually costs 6 times more than the time of the analysts that they're saving, which I thought was pretty ironic. And it leads him to state, I think, something that's pretty obvious for everybody, and that is building too much of what the world doesn't need typically ends badly. So you have to remember here in our hype cycle, there's going to be a lot of good stuff that we've seen, but there's also going to be a lot of garbage. And we need to be aware of that. Medicine has changed a lot. This image is probably familiar to most of you, a classic Norman Rockwell image of the doctor's visit. And you can see the warmth of a physician-patient relationship kind of put into this image by the artist. But let's fast forward into the 2000s and see what another artist had to say about medical care. And this is a drawing from a child who recently had gone to visit the physician and drew a picture of appreciation of that visit. And what you'll notice is the patient and their family are sitting around the examination table, and there is the physician back to them, typing away on the computer. A very different image than the 20th century one. But a couple of interesting points. Everybody in that image on the right is smiling, including the doctor who's busy typing away on the computer. So it's good to see that we're, at least from their perspective, the patient's perspective, we're happy. But the other thing I thought was really ironic as I looked at these two images is in neither of these images is the physician actually looking at the patient. Physicians are spending more and more amounts of time feeding data into the EHR. And I know for a lot of us, we wonder, are we physicians or are we data entry clerks? This article from 2020 in the Annals of Internal Medicine reported that physicians spend greater than 16 minutes per encounter in the EHR. How long is an encounter? Not much longer than 16 minutes. So you're spending a lot of your time with the computer instead of with patients. Vascular surgery residents, in this Journal of Vascular Surgery article from 2019, 20% of the vascular surgery residents' time in the EHR is after hours, or what we refer to as pajama time. And I bet a lot of you have spent a little bit of that pajama time in the EHR catching up on charts as well. But I've got good news for those of you in orthopedics. Not only, according to this 2020 article in Journal of Surgical Education, not only do non-surgical residents spend specifically more time in the EHR than surgical residents, so you're spending less time as surgeons than your clinical colleagues in primary care and hospital medicine. But as you can see from the middle bar, which actually represents orthopedic surgery, you're actually spending less time in the EHR than many of your other surgery colleagues as well. So again, a DALL-E 3 image, I asked it to produce an image of physicians busily typing into the EHR, and this is what it's generated. And I thought it was a nice image, but probably doesn't really reflect how physicians feel. So I asked it to try again and try to express some of the frustrations that physicians might have with the EHR, and it gave me this image instead. Probably many of you are more familiar with your colleagues looking like this than the image before. On the other side of the coin is this tsunami of health data that is overwhelming all of us. The quantity of data that we're being impacted by, again, is accelerating at an incredible rate. And many of us might feel like this person down there, feeling like you're about to be overwhelmed by this data tsunami. And this is where we begin to talk about where data literacy begins to come into this picture. But before I get there, let's define clinical informatics. And there are many definitions out there, but I happen to particularly like the one that the ACGME put together for the clinical informatics fellowship programs. And the things that I think are important about this definition, it's very wordy, but it's really about how clinical informatics will transform medical care through the application of not only information and communication systems, but more and more data, analytics, and AI. Clinical informatics, to cut to a short kind of an explanation, really transforms that data tsunami into not only information, but clinically actionable knowledge. And that's where we are heading. So it's not just throwing all this data at you, but it's doing some interpretation of that data and being able to bring that data in ways that it's easier for us with our, at least compared to computers, limited human brains to be able to digest this huge amount of information. And one interesting thing is to note from the doctor with the stethoscope on the computer and the cross across it is, we are not computer doctors. So early on in my journey in clinical informatics, my colleagues would call me up when their printer was jammed or they forgot their password. No, we're not computer doctors. What we work with more and more is the data itself, not even really the underlying IT systems. And that gets me to the point that clinical informatics is not just a subspecialty of medicine, but it is part of the practice of medicine we are all practicing today. And it's done it in a kind of insidious way, because many of us don't even realize that some of what we're doing is clinical informatics. And one of my challenges in trying to build educational programs is that many of you, our faculty, our attendings, say, I don't feel comfortable with this informatics stuff because I don't know anything about it. But then I point out to them all the things that they're doing every single day that is clinical informatics. So it's really blended itself into the practice of medicine. And that, in my mind, raised the question of, what does every physician need to know about informatics in order to feel comfortable with what they're already doing? Clinical informatics is, I add relatively, because we're not that new anymore. It's been 11 years since we had our first board examinations in clinical informatics. There are over 2,500 physicians board certified at this point. We have, as you heard, ACGME accredited fellowships. Geisinger is one among now about 70 fellowship programs around the country. We've grown quite quickly, faster than many of us thought we would. The interest in clinical informatics and to use data continues to grow. And we hear almost every single day from our colleagues working in the clinical space asking questions of curiosity about clinical informatics and how they can get more involved in it and what can they do to become more comfortable with a lot of these things. Here we go. Health data. We've treated health data for quite a long time as a byproduct of what we do, which is caring for patients. But we finally are coming to the realization that actually one of the other products we produce rather than health is health data. And there is incredible value to that health data that we need to care for our patients. We are also spending tremendous amounts of money in collecting, storing, organizing, and just beginning to use this data. Most health systems spend hundreds of millions, if not $1 billion or more, to implement an EHR for a system the size of Geisinger's. And so what we really need to recognize, and we have here at Geisinger and more places around the country, is our health data really warrants strategic consideration because it's not a byproduct of what we do. It's a very important product that arises from the work that we do every day. A lot of us have heard this term, big data. But many of us don't really understand what that means. And even people who use it all the time have struggled with this definition. So it's almost 10 years old now. But in pathology, as you can probably all well imagine, we have more data flowing through the laboratory than pretty much any place else in a health system. In fact, pathology, I believe, still encompasses over half of all of the data in an EHR. 5 or 10 years ago, it was over 70% of the data. So the laboratory has been working with big data since I started training 30 plus years ago. But yet, when we asked them, how do you define big data? Some of the answers we got were very interesting. Too much information to process or store on a single computer. Well, that sounds kind of good, but the little graph I put up there is the historical price of computer storage. And as you notice, the price of computer storage keeps getting lower and lower. And every time you go out and you buy a new computer, it has more storage and more power and more RAM and more everything. So what is a single computer anymore? So this isn't really a great definition for big data. How about a data set that exceeds a person's ability to manually evaluate all data points for reference? Not a good one either, and I'll show you why. From one of my pathology informatics colleagues, he produced a graph here, a little graph, which shows a scale of various different data, numbers of data elements for various pathology things, all the way from a single analyte, like you ordered a glucose, all the way up to time series genomic data. The dotted red line you see horizontally across the bottom, that's our brains. By the time you get to a comprehensive chemistry and a CBC, which is about 28 data elements, you have already exceeded the capacity of our brains, no matter how smart we are, to actually manually evaluate all data points for reference. So this isn't big data. This one seems pretty good, the kind of analytics that Google does. And in fact, here's an article where the CDC partnered with Google. And just by evaluating Google search data, Google was able to actually accurately estimate the incidence of influenza across the United States with a lag of about 1 week from the CDC data, just from what people type in to the search engines. That sounds like big data, right? It's Google, but it's not, and I'll show you why. Because what is big data? And all of us probably come and think of this first thing, volume. And about 23 or 4 years ago, an engineer, Doug Laney, had come up with these to define big data. And he started with 3. Now there are various groups. There are some people who talk about 10 of them. But I would say there are 4 that are really key. The original 3 of Doug's and 1 more. The first one is the one we all think about, the size and amount of data. Lots of it, right? The kind of analytics Google does. But that's not enough for big data. Just having lots of data doesn't make it big. Next V is variety, the diversity and range of different data. Well, let's think about health data. We have what we call unstructured data or text notes. We have semi-structured data. You know how in the notes you may have little drop-downs. So some of those elements in your note may be structured, is a term we refer to in computer science. We have numeric data from the lab. We have imaging data, all the little pixels in those CT scans. We have, what else do we have? We have images, we have genomic data now as well. Lots of different types of data. So you need a lot of variety of the data. So when you look at the Google example, while there's lots of data with Google, it's really only one thing. It's search engine entries. There's not a lot of variety to that data, which is why it's not big. Then you have velocity, which is the speed and the changing speeds of data flow. And as a pathologist, the best example I can think of is the flow of data through a hospital laboratory. Think of the rush of data that flows through the lab with morning labs, and then a fall off, and then maybe another peak later in the day. The speed at which data is moving is constantly changing, and that is really important to big data as well. And the last one, these are the original three Doug ones, and then the last one is veracity, and that is the truth or accuracy of the data. And one of the things about AI that we all have heard about is the struggle over getting AI to be consistently accurate. We've heard stories about what they're referring to as AI hallucinating, which is making up things, which I always thought was really funny because when I was a kid and I would make up some, story to explain something I had done to my parents, I should have just said, oh, I wasn't lying, I was just hallucinating, right? Health data is not a new problem. Over 125 years ago, Florence Nightingale said this, and I'll let you read it. But when you read through this quote, it becomes glaringly obvious that the questions she was asking towards the end of the 19th century and the beginnings of the 20th century are still the same questions we're struggling with today. Can we get data to show us what we're doing and whether we're doing good or we're not doing good? And how do we use data to actually improve the work that we do every single day? The good news I come to bring you today is I feel we are literally now on the cusp of trying to answer this question that has been posed for over a century. We're finally at a point we're able to begin to work with data in ways that we've been wanting to work with it for many, many years. Lots of places have recognized this. MIT Sloan Management Review about 10 years ago came out with this article where they showed that the best performing organizations, and this is not just healthcare, but across all industries, are twice as likely to actively apply informatics to their operational and strategic efforts. They also found, which probably wouldn't be a surprise to many of you, the main barriers to this are not technical. This is not a technical problem. This is a problem of culture and management or people. And in clinical informatics, we like to think of clinical informatics as the juncture of technology, people, and processes. And all three of those are equally important. A lot of people believe that we can slap a technology Band-Aid over a gaping wound of a bad process, but we can't. Technology doesn't solve underlying problems. It only facilitates what we're currently doing. Apply a technology solution to a bad workflow, and you've now got a bad workflow on steroids. In a 2005 book, Democratizing Innovation, Eric von Hippel states that the frontline workers, the people who are actually at the front line doing the work every single day, are the closest to real-world use cases and best positioned to develop solutions. This is not a top-down situation, this is a bottom-up. And that includes using data. Eric von Hippel also advocated for what he called these cross-functional agile teams, where diverse groups would come together to solve a problem and then dissolve. So it'd be kind of an on-need sort of process. And he believed that combining these two things would lead to a democratization of innovation within an organization. And that's, again, something we are striving for within healthcare. This article from the Proceedings of the National Academy of Sciences is a really interesting one in that they used an example of NASA Landsat data. And there was a period, I think in the 80s, where, 85 to 95, where NASA had outsourced this to a private company. And the private company, of course, raised prices, and they limited the ability of the user to share the images they had purchased with other users. And in 95, NASA took this over again, and they kind of went back to the old lower prices and free sharing of the data. And what did they find? There was not only increased quantity and quality of Landsat-enabled science, but the broader access enabled by these policies facilitated a diversity of scientists around the world to use that data. And what did they do? Many of them focused their questions on problems that were local to them. So we were looking now at different parts of the earth than we had traditionally been. And they had more interesting questions in many cases. So you had a great democratization of data through this process. And this is, to me, a really important point to understand how unlocking data can help very broadly. When we started our analytics journey at Geisinger several years ago, we were basically in this sort of a situation. We had lots of analytics. So on the surface, it all looked good. We have more tools, more reports, and more dashboards than most anybody else. The problem was there was little collaboration or coordination among the various people across Geisinger. And so while our clinical and operational stakeholders received lots of data, the value and usefulness of it was very questionable at times. The large percentage of these one-off requests led to a lot of data silos. Each department wanted their own data analyst to answer their questions, but the data analysts didn't really talk to each other. So the analysts in orthopedics didn't talk to the ones in pathology necessarily. Nobody knew what anybody else is doing. We had multiple different mechanisms to request data. So if you were looking for data, depending on what you were looking for, there were different pathways you had to take to go find it. And there was very little governance over which data requests would or would not be fulfilled. So what happened? The people with connections or the people who knew how to squawk the loudest would get stuff done, or the ones who had money and resources to get their own data analysts got stuff done, and other people just waited. Not a very good system, though on the surface it looked great. This is where we're heading to, and we're well along this journey. And in this more mature scenario, we envision that this data and analytics will be provided for you transparently without you even having to ask for it. That it's available as needed, the right data at the right time. Data and analytics would be automated and fit seamlessly into your workflow. And in the rare cases where a request was necessary, and we've already done this, there is one place you go to request it, not 6 or 10. And I'm going to talk more about our journey in a few minutes. And the interesting thing I would point out is many of the things we envisioned as part of our journey have been incorporated into this concept called data democratization, which I'm going to introduce in a minute. Ooh, wrong button. So what is data literacy? Data literacy is the ability to explore, understand, and communicate with data. And most of us have gotten little or no education about data, what it is, how to use it, or what we're supposed to do with it when we get it. When you look at some statistics, almost 90% of employees understand that they need to know more about data. They want to be more data literate. And 3/4 of people, and this is a broad survey, not just in healthcare, have access to some sort of data analytics or data analytics software or tools or reports. But only 20%, just over 20% of employees really feel confident in what they're doing when they're using data. This is a gap, this data literacy gap. And that's what myself and many others at Geisinger have really been trying to address, this data literacy gap. Because if you think about it, data literacy will support our workforce. By training our workforce in data literacy, they will be better at their jobs. They will be able to do their jobs more effectively. Not only that, we're developing our own internal talent. And multiple studies have shown the more you do that, the higher the chance of retention of those people. And the costs of replacing people are very high, and of course, always getting higher. So by training up our people and getting them more effective, our employees are happier in their jobs, and they're more likely to stay. When everybody has some knowledge of data literacy, when they do have to work with a data analyst, the quality of what is going to be produced is much higher because the quality of the conversation between the end user making the request and the data analyst will be much more robust, and they'll be able to understand each other much better. And then finally, we would all feel better if we understood more about data, dealing with the data that's being presented to us, or even the data we're trying to generate ourselves. So data literacy is a good thing, and it leads us to this concept of data democratization. And data democratization is about the decentralization and use of data to uncover opportunities and expedite decision-making. So through data democratization, going back to some of the references I talked about before, end users will be empowered to be able to explore data on their own and be able to leverage it in better ways than we've been able to leverage it before. And when you think of data democratization, of course, the first step is, well, we can't do any of this because, right, our security people have locked all this stuff up. I can't get to anything. So part of it is breaking down some of those security barriers in a safe way, not to make things dangerous in any way, but unlocking that tight access and control over data. But we realize that that's not enough because we can open the keys to the kingdom, but if people aren't comfortable in going through the door, they're not going to, and they're not going to use it. So this also includes promoting data literacy and encouraging what we refer to as a culture of data, where data just becomes part of what we want to do every day, part of what we are doing. And these are the best practices for data democratization. And you can see establish a culture of data, embrace self-service tools, implement organization-wide training and education, create broad data accessibility policies, and ensure high-quality data. And this is the journey we are taking, and now I want to lead you a little bit through how we've been implementing this journey at Geisinger. So in building a data culture, on the left side of the screen, we started by looking at what data and analytics resources we had across our enterprise. We went and sought out all of those data silos and all of the institutes and all of the departments and all of the various corners throughout Geisinger. And we reorganized it. We left, as you see in this diagram, you can see the outer circles. We left the analysts embedded in the areas in which they were assigned, because one thing we realized that's very important is the data analysts can function better when they're embedded in with the people they're working with. So if you understand the clinical workflows and you understand the people and the policies and the workflows, you are able to better serve that group as a data analyst than if you're just a data analyst in a random pool. So we didn't want to lose the value we were getting from the intimacy. But what we needed to do was pull those disparate groups together. And we created a hub of data management, data delivery, and data governance to kind of pull all these different spokes together into this hub where we could begin to collaborate, where we could begin to share, where we could begin to see where there was duplication of effort and begin to eliminate it, where we could begin to cross-train our analysts so that they could support multiple areas as needed. Because as we know, big data flows at different speeds, and attention may need to move from one area of the enterprise to another. On the right is the emblem of data literacy, of data governance for our system. And you notice the roof is championing data literacy, and it's founded on a foundation of optimizing data access, content, and quality with the point of delivering full value of our data. And as a result of starting to build this culture of data at Geisinger, we were able to break down silos, start to align data and analytics across our enterprise. We created common standards and procedures and definitions to facilitate all of that happening. We began to inventory and monitor analytics. So for the first time, we were actually able to create an inventory of all of the analytic tools that we actually had out there. And guess what we found? We had a lot of duplicate tools. We had a lot of tools that were obsolete. We had a lot of tools that no longer worked the way they should. And we had tools that nobody had used in years. So that enabled us to combine and shrink that inventory and better organize it. And guess what? It's easier to organize fewer tools than more tools. So it was an incredible increase in efficiency by doing that. On the right, you can see this is a graph of the requests that are coming into our office, into data and analytics from August of 23 through August of 24. And you can see, and this is, if we look at any year, it all looks the same. There's a lot of noise, but the trend is up. People want more data, more analytics, and the more we give them, the more they want. And that's created a big problem for us here on the lower right corner. We get in almost 2 more requests a day than we're able to produce. That's not sustainable. We need to figure out how to change that. And that's where this data literacy and self-serve analytics comes into play. So what is self-serve analytics? It allows users to access and analyze data themselves without having to rely on some expert or somebody else to do something for them. And our vision for this is and we're not suggesting that all of you are going to be data analysts and do all of this work yourself, but there are a lot of areas where the searches are relatively simple and straightforward. And if we can get all of us to self-serve some of that easier stuff, that will take pressure off of our data analysts, allowing them to focus on the more complex analytics where we need their expertise, rather than having them do simple stuff that any of us could easily be taught to do. The 2 tools I'm going to highlight now that we do for that are our Analytics Hub and Epic Slicer Dicer. So the Enterprise Analytics Hub at Geisinger is our one-stop location for all of our non-Epic analytics at this point. Yeah, and you're just thinking, wait, so that means there's this whole other pile of analytics in Epic. And yeah, there is. We are moving towards bringing those 2 things together. That's still ahead on our journey, probably still a year or 2 out. But what is this Enterprise Analytics Hub? It's easy to get to. You can either go to Quick Links, it's the first one on Quick Links, or if you just go to All Links, the Analytics Hub is right there. So it's easy to access from Geisinger's SharePoint site. You do have to be inside the Geisinger umbrella, so you can't just browse to this URL from outside in a browser. You need to log into Geisinger to get to it. And in our Analytics Hub, we've broken it up. You don't see all of them, but we have these 9 boxes broken into different areas, such as enterprise, access or patient flow, quality. You'll see there are bold. Some of these listings under them are bold, others are not. The ones that are not are individual tools, analytic tools. The bolded ones are folders of more analytic tools underneath them. And you can see, we literally have hundreds of different tools. So you're like, how do I find stuff? We've created a very functional advanced searching function to allow you to search the inventory to find what you may want. And we think this is the first step of self-service. Maybe you don't have to create something yourself. Maybe there's something already in existence that's going to help you answer your question. We've created a favorites. For people who use the hub regularly, and we have more and more people who do, you can add the tools you use frequently to a favorites folder, making it easier to get to when you need to get there repeatedly. Also a recently viewed if you want to go back to things you had just recently viewed. And one of the things that took us a while to get to is this one-click help. So if you don't have access to one of the tools, because you wouldn't necessarily have access to everything automatically, or if you have a question about one of the tools, or if you have a request, or if you just need help navigating this, there's one place to click for help. When you hover over a tool, here I've hovered over Proven Recovery, a window opens up, giving you a lot of metadata about that tool. So you can see it gives you a little description of the tool with an image. It gives you the name of the business and analytics owner. So say you're playing with this tool and you have a question, you now have people identified who are experts in this who might be able to help you with the questions that you have. We get a little bit of statistics on it. You can see how frequently the dashboard is refreshed, for example. This one is refreshed weekly. Some are refreshed daily, as they're all at different paces. And at the bottom, you'll notice these tags. And the tags are used to help in that advanced search. And guess what? As users, you can click up at the top to edit this. You can add tags to help you find these tools in the future. So we believe strongly in all of us in crowdsourcing this to make this tool better. So this tool is not my tool or informatics tool, it's our tools to use. And if you open up a tool, and this is the Proven Recovery dashboard, you'll notice that the dashboard has a bunch of filters across the top where you can make various choices to narrow this down to what specifically you want to look for. And because we're here, I picked total knee replacement, which is one of the Proven Recovery plans that we have. And you can see a whole bunch of data comes up that gives you a great overview. Case program volumes, risk-adjusted outcomes, a focus on the best practice elements and how we're doing, color-coded to make it easy for people to see areas that might need improvement or are doing very well. Very nice, robust tools, built by analysts, sophisticated, very flexible, hopefully easy for people to use, and providing great and valuable information to help us in our jobs every single day. Well, what if there isn't anything in the hub that you could use, or you're interested in the data within Epic? So within Epic, there's a tool called Slicer Dicer, and it's designed as a self-service tool for Epic users to be able to explore the data within Epic. And as you see, I love images in my presentations. And I didn't ask DALL-E 3 for one here, but if you go into Google Images, for example, and you type in, "give me Slicer Dicer," you get these images on the left. You don't get the one on the right. So you get a lot of images of these veggie slicers. And what was interesting is I started clicking through the images of the veggie slicers and looking at some of the websites behind them. And what I thought was really interesting was the way they described the veggie slicers was also a great way to describe Slicer Dicer. Simple and easy to use. Yeah, both are simple and easy to use. High quality. Okay, I guess the plastic stuff is high quality, but all right, it does the job. Most of us have these tools and they work pretty well. Flexible, right? Lots of different tools for your job. Same thing with Slicer Dicer. Safe. Slicer Dicer, well, safe. Hopefully you don't injure yourself. They try to make these safe. With Slicer Dicer, you can't break anything. You can't affect a patient through it. This is data being pulled from a data warehouse, which is separate from the database that we use for day-to-day patient care. So you cannot do anything in Slicer Dicer except dig yourself down a rabbit hole searching for data and having to start over. So there's nothing to fear in using this. You're not going to hurt anything at all. And there are multiple tools for different jobs. Yeah. Exactly. So I wanted to give you an example of how easy it is to use Slicer Dicer. So I'm posing this question: how many patients who had an amputation of their lower extremity in 2023 had associated osteomyelitis and/or sepsis? And on this slide, if it works, I'm going to show you how we do that in Slicer Dicer. Okay, there it goes. So first you pick a data model, and a data model is basically a subset of the data in the data warehouse. And we're using a large one, the patient's data model. Right now I'm looking for the patients who've had the procedure we're looking for, which is amputation of lower extremity. And I created a little grouper to include all the diagnoses we needed into that. I'm changing the date range for the calendar year 2023. You can see how the visualization changes as I go through. Now I'm looking for those patients who had osteomyelitis as a diagnosis. And Geisinger allows us to link those things together. I can change the labels, as you can see, very easily because we have the ones who had osteomyelitis and the ones who did not have osteomyelitis, so I changed it. Now I'm going to do the same thing, looking for the diagnosis of sepsis. And you can see, how long did that take? I've got the number of patients who had sepsis, who don't have sepsis. By hovering over, you can see the descriptions of these things. But we can go further. That was the number of patients. Now I'm looking at a different metric. I want to look at patients who have a history of alcohol use. And how does that change? Now you see we have percentages, and as the mouse hovers over the bars, you'll see it shows you how it calculated those, so you can confirm it did what you wanted to. But what I thought was interesting here is you see the alcohol-using population appears to have a higher percentage of sepsis. You know, nothing significant to look at, but it's just a way to explore data. Now I'm going to look for patients who've had a hemoglobin A1C greater than 6.5. And we can see they're much more likely to have osteo by percentages. Now, I'm not saying this is a great search or one that any of you would think would be valuable clinically, but it's really just an example of how easy it is to use Slicer-Dicer. In just a few minutes, you're able to quickly able to search through the data to find what you're looking for. And this is a simple search. You can get incredibly sophisticated in how you do this. But everyone doesn't have to be a Slicer-Dicer guru, right? Just being able to do this could be incredibly helpful. Think, if you're just trying to figure out, I have this idea for a research or a quality improvement project, but do we have enough patients to even make this worthwhile? This is a great way to quickly get an answer to that question. Because in the past, you'd put in a request for a data analyst, and it might be weeks or months before you'd get an answer. You can get an answer in 5 minutes. And in the end, you're going to understand the data better. You're going to become more comfortable with the data. And the next thing you know, you're going to be data literate without even realizing what's been going on. So what have we been doing at Geisinger to facilitate this? We've been doing a lot of training. And I'm going to go through each of these. I think I have a couple more minutes. Medical students' education in informatics. We have been doing a tremendous amount of work here at GCSOM, working with our med students in getting them data literate from the very beginning. So our preclinical med students, what we now call phase 1, we have them from the very beginning working in an EPIC training environment where they used to do their case-based learnings by typing, learning to write notes by typing it into a word processor and then uploading it to our LMS. They now type those notes directly into an EPIC training environment. So they're learning how to work in EPIC from the very beginning. We now can also, now that we have them in EPIC, we can also get them used to searching for a lab result. learning how to see where an X-ray is and how to pull it up. So we start teaching them skills from the very beginning. So at the point that they start their clinical rotations in year 3, in the 3rd year, what's now phase 2, they are already comfortable with our EHR and how to use it. We're also teaching our first-year medical students how to use Slicer Dicer. So using Slicer Dicer, they're actually able to begin to explore our data themselves. Our medical students, between their first and second year, many of them participate in a summer research immersion program. A perfect way for them to start using Slicer Dicer in the real world. For GME, this year we've launched a GME informatics track. We have 6 sessions open to any residency or fellowship throughout Geisinger. What do you need to know about informatics? What does every physician, every podiatrist need to know about informatics? We've created a series of sessions about that. And by the way, one of the first residencies who signed up for this is podiatry. So our podiatry residents will be going through the program this year, and it is open for any faculty who are interested. Just ask your program directors, get a link to these sessions, and if you can join, please do. We would love to have you and bring you along on this journey with our trainees. We've developed a core curriculum I'm going to show you in a minute. We have a monthly informatics seminar series, incredibly well attended, about 150 attendees per month, where we have both inside and outside speakers talk about cutting edge work that's going on within informatics. Dr. Trang will talk to you a little bit about Epic U and EHR efficiency training later this morning. And I've been leading the Slicer Dicer training throughout Geisinger. If you want to learn something about informatics, we have actually created a clinical informatics specialty guide on our health system library site. The beauty of the specialty guides is they're actually open outside the Geisinger network, so anybody can actually come and utilize this site. You can use the QR code or the link, or go to the library site yourself. You can see we've organized this into 14 modules of covering all the various areas of informatics, and you'll see some of them, many of them are not even technical, right? Project management, systems thinking, teamwork and collaboration are all things that are not necessarily technical, but critically important to informatics. Each one of these modules have topics with knowledge and skills for people to focus on. Every one of those topics and skills have a list of resources that have been curated and kind of organized as to, easy, medium, hard. And we've begun to, with the Pathways tab up there, create specific pathways. For example, for that GME informatics track, where all of the information that our residents and fellows will need going through that track are available in one place, yet they also have this whole site to explore for things they may have a bigger interest in. We have the informatics SharePoint site. If you go to our department, which is Enterprise Informatics, Analytics, and AI, and click on the training link, you'll see Epic U there. And again, Dr. Dang will talk about Epic U later this morning. But we also have an Epic Slicer Dicer training page. And if you click through the page, you'll see we have both instructor-led classes. So we're running classes every month on Slicer Dicer, 3 different levels of training. But we also have, as you see in the middle, self-paced data model training, where we've put together resources, literally walk you through various questions, real questions that people have asked from Slicer Dicer, and show you step by step how you go through answering them and learning how to do that. I would encourage all of you to take some time and explore these resources to really help you on your journey towards data literacy. So in conclusion, I think all of you can agree we have a data literacy gap. And it's nationwide. And while at Geisinger, we're maybe a half a step ahead of the crowd, we still have a long way to go. I hope you will agree that promoting data literacy and democratization is really necessary nationwide, worldwide, for us to really begin to turn this curve on data and technology and the overwhelming nature of it. As I said, this is a journey we have only just started. And as it comes from AI, and I'm sure Dr. Jeffries will have a lot more to say about it, we are on that hype roller coaster. So enjoy the ride. Thank you all very much. Appreciate your time.
One of my colleagues, we want to work smarter, not harder. And so as you're listening to the information that we're sharing with you today, I think it was really important to take home that Geisinger is ahead of the curve, realizing that the culture that we are trying to provide here is adopting the new technology, adopting the information, but also adapting. And what I liked, what you shared is, understanding that we need to have required people embedded, so not just data analysts, but those who are already in the trenches, I like to call it. They're invested in their own, I would say section, and then they can give back more information. So, that foundation is important. Geisinger has always been ahead of the curve with this, so we're not trying to reinvent. We need to use the tools we have, build a better mousetrap, so to speak, and really understand kind of what's behind the scenes and how we can kind of unveil that. Thank you for, putting a little just shout out to podiatry and that, it is the first group of residencies. And I have to, I would really want to highlight Dr. Branning and Dr. Nasser in there for overseeing the residency and really having that innovation and that foresight to include our foundation, which is our residents and our students, and that's also why we're here. So with that being said, we're going to work ahead to our case presentation. We have Dr. Cornwell. He is one of our orthopedic residents in surgery. He is a PGY3, and he is bringing a case presentation for us today. Welcome. Thank you.
Hey everyone, nice to meet you. I'm David Cornwell, PGY3 resident in orthopedic surgery. Honored to be here with Dr. Bharani today. And I'm presenting the Road Ahead Emerging Applications of Artificial Intelligence in Orthopedic Surgery alongside my mentor in this, Dr. Matthew Finelli. Dr. Levy just did a great job defining a lot of terms, but I want to briefly touch on just a few more. First thing is virtual reality. So when we're talking about augmented reality, which is what I'm going to be discussing a lot of during this talk, that's the majority of the application that we see in orthopedics currently, is that augmented reality. Augmented reality fundamentally is a composition of virtual reality and AI. Virtual reality creates an immersive virtual environment. Users have a sound and a visual associated with whatever this environment is that distracts them completely from the real world. It's typically provided via a headset or a screen, and this virtual reality, importantly, does not interact with the real world. Compare that to artificial intelligence, which is fundamentally a set of computer programs or an algorithm that is able to complete a task that was previously believed to require human intelligence to complete, if not superhuman concentration. AI, importantly, is able to do these things using a variety of different tools. Artificial intelligence itself is a broad scoping overview of a term that includes several different things. One of those things is machine learning, which you'll probably hear a lot about today. Machine learning and deep learning fundamentally operate as trial and error on steroids. If I were to give a brief example of machine learning, I would have 3 programs or 3 algorithms. Let's say that one of them is a created program that is the creator of other programs. Then I have my created programs that are intended to do a task. And then finally, I have my testing programs. So my creator program, which I have made, will design new bots, and those new bots are then tested on their ability to perform a task. Let's say, for example, that that task is identifying an apple. So I have my creator bots, it makes all these other bots, those bots go on to identify an apple, but they're horrible at it. And so they go to the tester bot says, how good are you at this, grades them all, and sends the ones that are most competent back to the creator bot. The creator bot then uses those bots and says, these are the best at doing this job, let's make another round. And that cycle then repeats itself with millions and millions and millions of iteration using all of this big data to be able to form a bot that can perfectly identify an apple. But it's not the apple we're interested in anymore. Now we're identifying diseased long-headed biceps tendon. We're identifying patients that have high risk of readmission to the hospital. AI also is able to use this machine learning to converse with people via what's known as natural language processing. So that provides the AI the ability to talk to people. And then finally, the AI is also able to recognize and adjust to real-time visuals and images using computer vision. VR and AI then combine to form the majority of the talk here, which is augmented reality, which is where virtual augments are added to real life. This augmented reality is either projected onto real life directly, or it's viewed through a screen or some form of enhanced visual display. If you'd like to check that out, Ray-Ban's just released a new augmented reality set of glasses. Importantly, in augmented reality, the real world and the virtual world overlap and interact with each other. So where are we currently using AI within orthopedics? There's some places in orthopedics where we use it on a daily basis. It's almost banal to us at this point. Preoperative planning using 3D reconstructed images is one of those. We may not think about that as being AI, but it's just a much older generation of AI, using those computer-generated pixels, as Dr. Levy mentioned, to be able to put together a 3D reconstruction. On a more niche side, we have navigation-assisted ACL tunnel placement, which, while currently doesn't have any clinical benefits, has been shown in some studies to have superior accuracy in posterior femoral tunnel placement. We also have AI working on the most important things in orthopedics, orthopedic oncology, shout out Dr. Bowen, looking at margin resection for tumors, specifically soft tissue sarcomas, which have been shown to continue to grow between the time that they are scanned and imaged and resected. And so we have AIs that are currently working to generate those margins. AI can also provide intraoperative aid to the surgeon as well. AR-assisted pedicle screw placement, which is seen here on the right, can show the surgeon in real time and directly in front of them as they interact with the instrument how that pedicle screw is going to be placed. And so that augmented reality not only increases the clinical accuracy of that pedicle screw placement, which has been shown in meta-analyses, but also dramatically decreases OR fluoroscopy time, as does the Tianji, which is a Chinese AI-assisted navigation tool. In this case, it's used for pelvic screw placement and was found to decrease OR fluoroscopy time by around 50%, which is fairly significant. But perhaps the augmented reality model that we're all most familiar with is the Mako Total Knee robotics. Soft tissue balancing and cut planning for the Mako Total Knee uses an intraoperative augmented reality model. And it does this by taking preoperative CT data and then taking intraoperative data from relatively fixed sensors. So those relatively fixed sensors are implanted into the leg, in both the femur and the tibia. And then the surgeon verifies and validates the CT as compared to the real-life data of the patient by registering that patient via the system. This data is then combined to work as shown. You have an augmented reality model, which is able to interact with the surgeon as they operate. As I move the saw, that augmented reality model can tell exactly where that saw is and will move accordingly. This allows me and the surgeons operating to be able to record that real-time data and then balance soft tissue tension prior to any cuts being made, allowing for implant placement to be personalized to that patient, which is really pretty remarkable. Reduces the ability reduces the need for surgeons to recut as well. So any final soft tissue tensioning is done before cuts are even made in the first place. But the area of arthroscopy is the one that I want to touch on here the most. Arthroscopy is a technically challenging tool within orthopedics. And any attending or senior resident of mine can tell you, you get limited practice with arthroscopy during residency. It's something that takes a lot of practice to be good at, and it's something that is difficult to practice outside of a real-life simulation. Even cadavers can sometimes have limited utility with arthroscopy. There are several big problems that are dealt with via arthroscopy, and arthroscopy is the superior tool for navigating these problems. For example, femoroacetabular impingement. Femoroacetabular impingement can be grossly broken up into three types: overgrowth of the acetabulum or pincer-type deformity, overgrowth of the femur or cam-type deformity, or a combination thereof. And it is this cam deformity that I want to mention here. The most common reason for revision hip arthroscopy is in the case of femoroacetabular impingement. Specifically, of those revision arthroscopy cases, the most common reason for revision was under-resection of a cam deformity. You can see up there that you see that cam deformity and the area that needs to be resected. But because the femoral head is a sphere, you can't see accurately the three-dimensional outline of this sphere via one two-dimensional fluoroscopic image, which lends itself to under-resection, because you really don't want to over-resect, because over-resection of the femoral neck and over-resection of the cam lesion can lead to increased rates of femoral neck fracture, higher conversion to total hip arthroplasty, and also can defeat the purpose of the surgery in entirety by causing destruction of the labral suction seal. Part of the damage acquired via the cam deformity is damage to the labrum in the first place, part of what you hope to repair. Which leads us to the next generation of femoroplasty, AI-assisted femoroplasty. So femoroplasty currently uses 6 different fluoroscopic planes to evaluate that cam deformity. AI has taken that, and similarly to the Mako total knee, has a preoperative CT. That preoperative CT is able to be evaluated for perfect sphericity of the femoral head, and then anything outside of that being the cam deformity. That cam deformity is then able to be presented to the surgeon as an augmented reality model. And in the so far limited clinical trials that exist on this augmented reality resection of cam deformity, it's been pretty tremendous. 91.3% of resections were within a 3 millimeter margin of error. And of resections that fell outside of those 3 millimeters, which were very small, only 5% of them were within a 5 millimeter gap. The maximum observed deviation was 6.3 millimeters of over-resection and 7.1 millimeters of under-resection, which is significantly less than the non-augmented reality models have seen. Another area that I want to touch on and close with here is AI-assisted rotator cuff anchor placement. If operating in the hip is one technical challenge, then operating in the shoulder can certainly be viewed as another, sometimes even higher level of technical challenge. And it can be very difficult as a novice learner. An AI model, in order to help both experts and novices, was created to place rotator cuff suture anchors. This AI model was able to track not only the hands of the surgeons and the instruments, but also the scope itself, and was able to guide expert surgeons and novice surgeons, who both saw benefits, but different benefits. The expert group was able to properly place their second anchors with greater accuracy using this AI model. So that vertical angle that you see down here with red was the initial placement of the second anchor during rotator cuff arthroscopy. Now, the truth here, as planned by the researchers, was the blue one you can see there. So if the attending surgeon had planned to put in a different spot in the red, then that might be why. But you can see that the consistency with the first anchor up in figure 1 on the very far side was fairly similar to first anchor without any AI navigation versus first anchor with AI navigation. And so that anchor placement significantly improved on the second anchor placement with that AI navigation. But perhaps more interesting than what the experts saw in improvement was what the novices saw in improvement. The novices had a tremendous improvement in not only the number of movements and the time taken, but also in the mean path of the scope itself, which really lends itself to the core of the Perenni Symposium, which is education. AI is a tool, like anything else we use in orthopedics. And it can be viewed sometimes as a scary tool, a tool that we don't understand. But fundamentally, what it is a tool. AI-generated navigation can assist both experts in their placement, but also in training of novices. So I really want to emphasize that the next time you see AI being brought into the conversation for orthopedics, think of yourself not as someone who's being usurped or not as someone who's being given an unfair advantage, but as someone who's being given a new tool. Thank you.
Thank you so much. That was excellent, and I appreciate you circling back to the educational platform. And again, we have our donor Arturo and his wife Nina watching, and they've sent me a couple of messages. They're excited about the information that we're gathering, and one of the big question marks or the exclamation points when you were speaking, Dr. Levy, was being able to gather that information on infection, osteomyelitis. And so, you know, as we are adding these layers, I want to take us back to our next speaker, who we are going to look at the EPIC utilization. And remember, we are doing this maybe in the trenches, but there is a lot of behind the scenes. And so, as an informatician and also an internal medicine physician, Dr. Dang kind of brings both of the best of the both worlds, just being able to garner that information. But I know from a lot of colleagues who've contacted me, she has been a great assist in being able to utilize EPIC and utilize it to its optimal level. So without further ado, please come to the podium, introducing Dr. Dang.
Morning, everyone. I'm Trang. I'm gonna talk about becoming EPIC. So, time motion studies have shown that on average, physicians spend 1 to 2 hours in the EHR per hour of face-to-face time with patients. Additionally, they spend a similar amount of their personal time for EHR-related activities. Not surprisingly, this causes a conflict between work-life balance. And in 2021, physician burnout spiked to 63%. During the pandemic, it's not surprising that burnout was prominent. At that time, 2 out of 3 physicians experienced burnout, and 1 out of 5 intended to leave medicine in the next 2 years, while 1 out of 3 physicians planned on decreasing their clinical hours. Burnout can affect patient care, healthcare systems, and also the physician health. With the intention of 1 out of 5 physicians planning to leave medicine, replacing physicians on average will cost between $250,000 to $1 million, depending on the specialty. Nurses, they're twice as likely to leave medicine in the next 2 years. And the aggregate cost of reducing hours between both physicians and nurses is estimated to be $4.6 billion. And as we know, there is also a physician shortage, so this will further exacerbate this. Dr. Ehrenfeld noted that the physician shortage that we have long feared is already here. By 2033, it is estimated to be between 54 to 139,000, and for surgeons, it's between close to 16,000 to 30,000, with an estimated deficit of about 5,000 in orthopedic surgery. So let's look at the burnout rate across some of the specialties. You can see that emergency medicine, out of all the specialties, they're the top one experiencing burnout at 63%. Orthopedic is a little bit lower on the list at 44%. In this small study looking at burnout rates across orthopedic subspecialties, you can see that 100% of the oncology specialists were experiencing burnout. (70% to 75% of physicians identify the EHR as a primary source of burnout. We know that there are other various factors, but we won't discuss them today. EHR-related burnout can be related to time demands, administrative burden, documentation burden, complex usability, along with the ever-increasing message volume, and this contributes to an increase in cognitive load. It's important to note that all of these factors are interrelated and can exacerbate one another. 63% of physicians state that the EHR impact their work-life balance. Those that felt that they spent a moderate amount of time in the EHR at home were twice as likely to experience burnout. Similarly, those that were spending at least 6 hours per week after hours in the EHR were also twice as likely to experience burnout. Let's look at some of the data. So the first bar graph is an average of ambulatory providers at Geisinger. So on average, we are spending close to 21 minutes per day outside of our work hours, the pajama time. In the literature, it's been reported that orthopedics overall spend a similar amount. However, at Geisinger, orthopedic is actually spending less, just under 15 minutes per day outside of the EHR. And podiatry is spending close to the Geisinger ambulatory average. In addition to pajama time, we also will spend time in Epic on our unscheduled work days. So Geisinger overall is close to 29 minutes per day. Outside literature reported close to 25 minutes per day, and Geisinger orthopedics just under 10 minutes per day, while podiatry is just under 25 minutes per day. So you can see the data so far that Geisinger orthopedics seems pretty effective. They spend less time outside of the work hours. We also know that insufficient documentation time contribute to burnout. Providers with the highest number of patient calls were 4 times as likely to experience burnout. And those that were in the top 25 percentile in terms of message volume, they were 6 times as likely to experience burnout. As Dr. Levy mentioned, there is actually an ongoing pilot with Abridge using ambient documentation to help decrease documentation time. We have a group of 10 pre-pilot test users, and next week the remaining 90 providers will be using ambient. In the future, we are planning to use ART to help with the in-basket. ART is Epic's augmented response technology, which will help us draft a message for us to use and update. Epic also has something called Signal. Signal is Epic's report that measures how a provider spends their time in the EHR. So it is a data-driven approach to measure provider efficiency. It both compares you to within the system and also across the Epic community. There's both outpatient and inpatient, and you can see that the categories are very similar, with the main difference being the in-basket for outpatient providers and communications for inpatient. So let's take a look at some data for Geisinger Orthopedics. This was at the beginning of September. You can see that compared to their colleagues at other Epic institutions, they are spending more time in the in-basket at 8.6 minutes per day, which is considered to be at the bottom 25%. The average is 7.4 minutes. Looking at the in-basket, they also receive on average 36 in-basket messages per provider, putting them at the bottom 10%. And at other institutions, orthopedic providers receive on average 21 in-basket messages per day. Let's not forget about podiatry. So this is their Signal report. You can see that they are also spending more time in the in-basket compared to their other colleagues. And now we're going to drill down further to see what the in-basket metrics are. So you can see that there are 3 providers that are spending more time in the in-basket compared to their colleagues. And there's this one provider that's sort of an outlier in terms of the number of in-basket message they're receiving. They're receiving more, close to 2 times as much as their colleagues. Is there a reason why? In the sea of red, there's some hope, which is the green. So let's take a peek at what the green means. So for Signal, green means great. So that means usually we're in the top 10 percentile of something. In this case, for podiatry, it's the top 10 percentile of using quick actions. So a quick action helps save clicks and typing for common things. So instead of clicking reply and then typing your dot, blah, 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 you can actually combine that into one button called a quick action. However, if we're looking at the details, only 2 podiatrists are using quick actions. So the question is this really helpful? So for a provider that does not use quick actions, you can see that their in-basket time is around 18 minutes per day. For the provider that did use quick actions, they are spending about less than 10 minutes per day in the in-basket, suggesting that quick actions might be a way to decrease time in the in-basket. We can also look at individual level data for each provider. So let's take this example. This is for provider A. Provider A is the top blue bar, while the average department is the lower orange bar. You can see that they're doing great in the in-basket, along with orders, notes. Clinical review, they're about close to average. Time and schedule, it may look a little bit frightening because their graph is pretty long compared to the average, but when you look at it clinically, They might be in their schedule waiting for patients to be roomed. So now let's take a look at provider B. You can see a significant difference with two things sticking out. They're spending a great deal of time in the in-basket along with their notes. Look at the blue bar graph for the notes, more than 2 times. And then we could do a deeper dive into provider B to help identify what their pain points are. So this is a detailed review, and you can see the breakdown in how they are spending the time in the in-basket based off of patient message types. So they're spending most of their time with the medical advice, or the MyChart messages, staff messages, and patient calls. And then this is the breakdown of the type of messages that they are receiving to add the numbers to their in-basket. For some reason, they're receiving a lot of charts compared to their colleagues, along with staff messages. We can also do a deeper dive into the notes, and you can see that they are using a significant amount of copying and pasting. So is this contributing to the time in their note documentation? Because oftentimes we would need to edit it. Additionally, we can also look at their pajamas time, and you can see that they're spending a lot of pajama time along with additional outside hours on their unscheduled days. To get a better definition of the metrics in Signal, you can also click on the eye icon to see how these metrics are defined. Lastly, you can also look at how many of their notes are closed. For this provider, most of their notes are closed after 1 week. To request access to Signal, you can visit signal.epic.com, log in with your Geisinger ID, and then request access. We just want to note that it can take several days to obtain access, but if you're interested in just your report, you can send me an email at mdang@geisinger.edu. Just make sure it's M as in morning, because there's another Dr. Dang. Lastly, as Dr. Levy mentioned, we have created resources, because the biggest question is, well, now I have this data, what do I do about it? How do I fix it? So Dr. Pura Gunta created EpicU, which is supposed to serve as a one-stop shop to provide resources on how to utilize Epic more efficiently. The goal is to be generalizable so that different roles, such as providers, nurses, and also PAR staff can use some of the tips and tricks. So 2 main sections are the tips slide deck. So there's over 70 tips, and it's broken down into these main categories. Let's say that we're interested in ordering. So clicking on that will give you selections of different tips. The right-click mouse seems interesting, so let's click that. And then you will see a tip in one slide. So if you're not aware, instead of using your mouse to click the accept button that's located at the top or bottom, you can just right-click on any white space in the order, and it will accept your order for you. If you're a keyboard person, you can also use Alt-A together. In addition to the slide deck, we also have a video library broken into 2 main categories. One is the in-basket, which is mainly focused towards providers, while the other one is a general tips and tricks, which is applicable across all roles. Additionally, we also have Epic efficiency workshops. If there's something that's bothering you, you can reach out to us. which is coordinated by Heather Finn. I think she's sitting in the back there. And we can review your EPIC signal report and come up with plans and solutions. Additionally, each specialty has informatics representative, at least one nurse informatician, and one physician informatician. For orthopedics, it's Cindy and myself. For other departments, if you want to know who your informatics representatives are, visit Epic U and then click the bottom link, contact your informatics representative. Recently, one of the providers noted that documentation was causing them pain and they were spending too much time in their notes. Working with them, we realized that their note template was inefficient. They were deleting a lot of things for an existing template because it wasn't catered to their location. So updating this, they noted that they saved time in terms of their documentation time. So this was a quick win. Updating the note templates, they were able to use speed buttons, and this provider has 11. So what a speed button does is if you ever notice these little gray buttons when you're making your note, clicking on it will automatically open that note template so you don't have to type your dot phrase each time. And we also have a tip on how to make these speed buttons. It is also available inpatient as well, which was a recent functionality. Lastly, Epic also has courses if you want to take formal courses. There will be Smart Week coming up, and this is the information if you're interested in registering. Lastly, Geisinger has the Provider Builder program, which gives you behind-the-scenes powers to build tools for your departments. As of 2023, we have 25 active builders who completed over 139 projects, and these are the specialties where the builders are located. Recently, we have new members from transplant and infectious disease. If you're interested in learning more about becoming a builder, you can email Heather Finn or Dr. Kyle Marshall. Thank you.
Thank you. As we bring our other presenter up, I want to take a couple of seconds to say forever learner right here. To take the mystery out of who the outlier was in podiatry, everybody in podiatry can take a breath because that outlier was me. Dr. Dang didn't tell me. Actually, I had the behind-the-scenes opportunity to have a colleague in primary care, Dr. Kevin Lee. I don't know if he's here today, but we would talk back and forth in Elysburg, and he said, Kathia, maybe I can help you. Unbeknownst to me that he was going to be leaving primary care, join the informatics team, and he ran a signal report for me. And he contacted me, and the first thing he said is, you need to sleep more. And I just said, what are you talking about? Showed me that. But there is power in knowledge and transparency. And so I've been floating solo for 9 months, and a big shout out to my new partner, Dr. Micho, because the inbox was, me as two people. So when you see that, I think it really helped me validate a lot of things, both for my team, for myself, for the department, in how much these tools mean and to be able to use them in the right way. So I have to say I have a lot of really great speed buttons, still working on the template. And again, this is a learning process to not just make it better for my patients, for my team, but also reducing that burnout and being able to do what we're meant to do. So, we're trying to stay on point. We will have a break. I know most of you are probably thinking we're a little bit off track. We're trying to integrate some of the case studies in here as well. And so I'm going to go ahead and bring our next presenter. Let me make sure. We've got Dr. Ayar here from podiatry. He is also PGY3 and going to present the opportunities for proactive care. Dr. Yap? Thank you.
Okay, good morning, everyone. It's an honor and pleasure to be allowed to present today at the Dr. Parenti Lectureship Limb Salvage Conference. Again, my name is Sri Hari Iyer. I'm a third-year podiatry resident at Geisinger under the guidance of Dr. Nasser, Dr. Branning, and Dr. Machicki. We're all here today. And I'm going to be talking about opportunities for proactive care, calcaneal gait after Achilles injury. So just a little quick overview of how my lecture is kind of going to go. It'll be pretty short and sweet. I know everyone's probably dying to get to break time, so I'll keep it short. But we're going to go over an overview of calcaneal gait, a little bit of an in-depth review about a particular case of one of our patients, and then kind of segue into a literature review. So just a introduction about calcaneal gait. So what is calcaneal gait? So for people who might not be familiar with that, it's really kind of what it says. It's really walking on your heel in layman terms, right? In more advanced biomechanical terms, we kind of notice a couple of things about calcaneal gait. You'll probably notice an increase in plantar rear foot pressure, a decrease in forefoot pressure, and then during the gait cycle, which I will be showing in the next slide, you kind of show that there's a delay in push-off and progression to terminal stance. So here's like a little cartoon about the gait cycle. I know a lot of podiatry colleagues of mine are surely familiar with this. For those who may not be familiar, this is kind of what we usually spend a lot of our time kind of taking a look at when we first work up a new patient, right? So it's kind of divided into two phases. We have the stance phase, which constitutes approximately 60 to 62% of the gait cycle, and swing phase, which constitutes the minority, around 38%. And in calcaneal gait, the issues usually actually occur during terminal stance, which kind of involve the three broad categories of mid-stance, terminal stance, and pre-swing. And these are those areas that are right before your heel actually lifts off the ground in order to propulse and be able to get motion going. So what usually happens is that you usually have an increased amount of inflammation at the heel. And what that does is that increases plantar heel pressures, leading to pre-ulcerative hyperkeratosis. And in the sensate patient, they can accurately feel what's going on. They can understand what's happening and understand those sensations. However, in a neuropathic patient, you tend to notice that they are not necessarily aware because of the loss of sensation, both protective and light touch. So just to kind of quickly segue into our case presentation. So we have a 38-year-old male with a past medical history significant for type 2 diabetes, hyperlipidemia, chronic kidney disease, venous insufficiency, and morbid obesity, who was admitted back in 2020 of September for a right submetatarsal 5 chronic ulceration with positive probe to bone and some infected looking serosanguinous / seropurulent drainage. On an initial examination, the pulses seemed to be intact. There was good capillary refill time to the foot. Of course, neuropathically speaking, he was a little bit insensate, a little bit of loss of protective sensation, as well as orthopedically speaking, he had pretty good active range of motion to his digits, to his ankle, and to his subtalar joint on passive examination. Of course, the elephant in the room was that, oh, there it is. Ulceration noted to the right aspect of the lateral column of the foot. And kind of looking on examination of this ulceration, you kind of note that it's kind of gunky looking. It has this very necrotic base, a lot of fibrotic tissue, and kind of looks a little bit boggy as well. X-rays then confirmed that there was some degree of osteomyelitis to the cuboid and then to the 5th metatarsal in this patient's foot. In addition, there were some areas on the x-ray, as you might be able to notice, which corresponds to lytic destruction of the bones that I mentioned before, here and here as well, with, of course, some degree of soft tissue emphysema. So, of course, this was considered relatively emergent, and the patient then was consented for a right fifth metatarsal resection with incision and drainage. Cultures were, of course, appropriately taken intraoperatively for both bone culture and pathology, and kind of revealed that there was some degree of acute and chronic osteomyelitis. So as this patient's care progressed, the image that you see here on the top left corner is right after post-debridement at the initial surgical intervention. It was noted that, of course, since there was some issues with the bone, those bones and the patient had to be considered for continued IV antibiotic therapy. And then further, he had, of course, some degree of equinus that was noted during the physical examination on his initial workup. However, due to poor skin quality at the time and surrounding venous insufficiency ulcerations to the posterior aspect of his heel, surgical intervention in terms of a Achilles lengthening procedure could not be considered at this time. So what happened is, again, after working with infectious disease and our multidisciplinary approach at Geisinger, we then determined that we had to do a repeat incision and drainage with the application of a wound vac. And this was to help to facilitate granulation to the wound and trying to get some of those deeper vascular-rich layers to kind of continue to have good soft tissue coverage to the wound as well and to allow this patient to heal. However, again, when we took another intraoperative culture, we noted that there was still some degree of osteomyelitis to the fifth metatarsal. So, as this patient was in the hospital, we continued to perform local wound care and try to get the patient to offload as much as possible while supine in bed at this time. Finally, at some point, we were able to kind of get enough skin integrity to the posterior aspect of his heel in order to be able to perform a lengthening procedure to offload some of those forefoot pressures and the lateral column a little bit better. So following this, we had another fifth-ray resection, a cuboid resection, in order to try and eradicate some of that infection from the deep recesses of the foot, as well as a tendo-Achilles lengthening procedure. Because by this time, the patient had already been on suppressive antibiotics and was, again, still not at a final stage of curative restoration. So pathology results did show that there was some degree of acute and chronic osteomyelitis to the bones that were excised from the patient's foot at this time. But otherwise, the patient was then continuing to granulate and allowed the wound to heal, continuing negative pressure wound therapy as was directed in order to facilitate better wound healing. And finally, back in 2020, towards the end of December, we kind of get to this picture here at the bottom right corner, actually, which shows increased soft tissue coverage as well as healing of the wound to the right lower extremity. In the interim between his discharge at this first hospital admission and today, we kind of noticed that in his care during the wound care clinic, we noticed recurrent sets of ulcerations. And some of this was also because of the patient's poor body habitus and inability to be able to offload his foot effectively. We noted that he was wearing slippers, different kinds of shoe gears that were not necessarily heel offloading to the right lower extremity, and to the left he was wearing a cam boot or a controlled ankle motion boot at that time, which was also leading to a biomechanical imbalance in terms of gait analysis. So some of this was also preempted as well because of that as well. And also in addition to this, due to his longstanding chronicity of venous insufficiency, he was continuing to use lymph edema pumps in order to help better facilitate, control the amount of swelling that was in the limb, which was also causing recalcitrant ulcerations as well. So if you notice here, to the top left and to the top right corner, this is his heel after several months of localized wound care, offloading using a flat surgical shoe. And you can see that this is despite everyone's best efforts. Unfortunately, he couldn't tolerate a heel relief shoe. And so this is kind of the result when he initially noticed a suctioning kind of sensation to the plantar aspect of his right heel. And eventually, we started noticing that he had increased systemic signs of illness, fevers, nausea, chills, vomiting, and the list goes on. And at some point, we felt that he had to be admitted to the hospital for evaluation and further workup. Part of that further workup involved an MRI to the right lower extremity. And we kind of noticed at that time that after his tendo Achilles lengthening procedure that was done previously, he was noticing to have some degree of partial tears to the Achilles tendon, which was noted with a decreased T1 signaling to the calcaneus with, again, clinical correspondence to the plantar calcaneal ulcer. In addition to this, we also noted some degrees of possible osteomyelitis owing to the bone marrow edema, soft tissue emphysema, as well as soft tissue necrosis, as you can see in the top right image over there. At the bottom of this screen, you will notice that there's a nice big giant gaping hole. That is not by accident. That was actually done by us in order to be able to get rid of that infection and be able to eradicate some of the soft tissue emphysema that was still noticeably present despite prior antibiotic therapy as well as local wound care. So at this time, we were, of course, very much relieved to note that there was a negative bone culture that was initially procured. Everything seems to be looking great at this time. However, there is a little bit of a twist that will be coming up. So in making sure that the patient was actually being able to offload, he was non-weight bearing and put in, of course, a non-weight bearing shoe while he was in the hospital, and then dispensed and discharged from the hospital with home health as well as a home wound vac in order to help facilitate additional closure. And if you look to the image to your left, you can kind of see that there's some degree of heel gate that is still noticeably present even in the radiographic images. So the patient was then readmitted at this time to the hospital following failure of oral antibiotic therapy, but his heel was still noticeably seropurulent at this time with increased malodor as well as signs of systemic infection, this time with dry heaving. Again, during this time, the patient's body habitus was still noticeably not very good at this time. And he started showing more and more systemic signs of illness until, again, an MRI did confirm the presence of osteomyelitis to the calcaneus. So finally, at this time, we did decide that we had to consider something a bit more aggressive. And at this time, he was consented for a partial calcanectomy with excisional debridement to the level of bone. Once this was performed, it was noted that, okay, there was, of course, areas of acute and osteomyelitis to the heel. And it was also noted that, again, he would probably need to go for something potentially more definitive, a more proximal amputation procedure. However, in the interest of this conference, and especially in the interest of this patient, he was initially not on board until he felt that this was a cyclical process that might be more cumbersome rather than actually helpful. So once the clean margins came back from the surgical pathology, it simply noted that there was chronic osteomyelitis to the clean margin, even after taking and procuring excessive bone from the heel. The patient, of course, at this time was at risk for pathologic fracture as well as stress fracturing due to the already resected amount of heel bone that was noted, and to the pull of the Achilles tendon, despite the tendo Achilles lengthening procedure that was done previously. And so it was at this time, after a long interdisciplinary talk with infectious disease, with his nutritional management, with endocrine, it was noted that he might need to go for something like a below-the-knee amputation. And after a lengthy discussion with vascular surgery, it was noted that because of this patient's poor body habitus, with a BMI of approximately 58.32, he would not be an actual good candidate for such a definitive procedure for several reasons, one of them being his body habitus, and two, due to the longstanding venous insufficiency that would not allow for either primary closure or more definitive treatment. So I just want to go at this time into a little bit of a delve with a couple of articles that might highlight what I'm talking about a little bit better. In this first article by Weibel et al. 2019, we do note that there are a couple of things that are going on here. We're looking at 3 index procedures. We're looking at a partial calcanectomy, total calcanectomy, and below-the-knee amputations. In the pie charts that you see up here, we kind of note that for the partial calcanectomy, the rate of no revision that was actually needed as an ancillary or secondary procedure is around 42.9%. We contrast that with the total calcanectomy, which notes that, as you can see, there is no line or part of the pie chart that is ascribed to no revision. And that is because all patients who underwent a total calcanectomy in the study did have to undergo some kind of revisional surgery. The revisional surgery could have been broken up into minor and major procedures. Minor procedures were considered as soft tissue, and major procedures were considered as ones that involved bony resection. In the areas for below-the-knee amputation, of course, 72.2% of the patients did not need a further revisional surgery. However, they still did go on to undergo a secondary amputation at 5.6%. So what this basically did show is that partial calcanectomies are a valuable limb salvage option at this time for a patient, with at least 42.9% of the patients not requiring revisional surgery versus the total calcanectomy. And on the face of that, that may not seem like a lot, but contrast that with the 100% of total calcanectomy patients who actually had to undergo revisional surgery. That is a pretty good number of limb salvage if you compare and contrast that. Another article by Dirk Scheid et al. 2024, which was a level 3 systematic review of approximately 490 cases, was also notably important in this aspect. In this study, we did note that there was an overall complication rate of 27.8% for patients who were diabetic who underwent a percutaneous tendo-Achilles lengthening for the treatment of diabetic foot ulcerations. And why this is important is that it also kind of looked at the rate of re-ulceration and transfer lesions to the heel. And we also note that certainly with tendo-Achilles lengthening, that is certainly a complication that can happen. Over-lengthening is certainly an issue at times when performing these tendo-Achilles lengthening. And because of that, that leads to calcaneal gait and an increased plantar rear foot pressures versus forefoot pressures. In this particular study, it was also noted that the incidence of patients who needed to undergo secondary ancillary procedures was relatively lower. And the reason for this was because of the fact that the current patient population in this study was carefully chosen. Most of these patients were well-controlled diabetics who had A1Cs at or around 6.5 and had good blood glycemic control that's performed by their endocrinologists. So while this may not be a necessarily comprehensive study that might be largely discernible to the rest of our population, some of whom might be uncontrolled diabetics or people with other significant comorbidities, this is certainly promising because it does show that this is an option that can also be used as limb salvage. A third article that I want to talk about is a level 3 case control prognostic study by Ha et al. 2010. If you look at the image on your top left aspect of your screen, you kind of can see that the positive values here reflect dorsiflexion, the negative values reflect plantar flexion, And the dark gray on both of these screens reflect patient, and the light gray is normal. So 2 gait analyses were done in this study of 58 patients without triceps serrae lengthening. And this was a study of cerebral palsy patients. So what it basically showed by the end of study 1 and study 2 of both gait analysis is that at least 28% of the patient population showed a greater passive dorsiflexion range of motion with the knee flexed, as well as increased plantar flexury weakness. What this basically shows is that patients with or without weight gain, as noted by this chart here, also showed an increase in BMI, which also contributed to patients with increased calcaneal gait issues, as well as increased plantar rear foot issues. And in addition to this, it also shows that in the dark gray aspects of the top chart up top, you can also see that there's increased amounts of dorsiflexion by the end of the second gait analysis compared to the initial gait analysis, which also shows that these patients, from a neurological standpoint, also showed a preponderance towards gait at the calcaneus. And just to end on a positive note, all is not lost. There are ways of actually preventing this from happening. In my final literature review article by Freiberg et al. 2017, we note that in 132 participants with diabetes and prior DFU in this 34-week cohort study, we can actually use artificial intelligence to use thermometric measures in order to measure some of these patients' plantar pressures. And what this does is that in, of course, patients with good blood flow, you're able to measure the amount of pressure based on the actual heat distribution and heat asymmetry that is used on these thermometric mats that are impregnated with artificial intelligence chips, which transmit the information directly to the providers through their personal devices or through health systems such as Epic. So in this particular study, we note that a lot of things were being done. 2 goals were trying to be addressed. 1, the development of non-acute diabetic foot ulcers, and 2, the accuracy of these mats in actually being able to predict the occurrence of diabetic foot ulcers over asymmetric thresholds. The results effectively showed that there was a total of 53 diabetic foot ulcers that were notably developed throughout the course of this study, approximately 37 out of 129 patients, with a 97% accuracy rate and a standard asymmetry of at least 2.22 degrees Celsius. And while this may not seem much, I would encourage you to look at the increasing temperature note over there at the bottom of the screen. So increasing the temperature threshold to 3.2 degrees Celsius decreased the sensitivity to at least 70%. And what does this really mean in layman's terms? What this means is that this mat might actually be promising for future for people involved in lower extremity care. Part of what we do as podiatrists is also trying to work on limb salvage and preventative measures with surgical options that need to be considered towards the terminal aspect once all conservative measures have failed. This mat does show a promise towards the future with the use of artificial intelligence and the use of future forthcoming technology in being able to reduce morbidity, mortality, and increase and propagate resource utilization in order to better assist patient care. As all of our speakers have talked about today, artificial intelligence is certainly the wave of the future and is also a way for us to use these tools to augment our practice as we directly interact with our patients and not necessarily use the technology to be a substitute for direct patient care. Thank you.
So thank you so much to all of our speakers. Thank you for that. And just to note, our donor did also reach out and say, you know, how important wearables, something like this, having a mat that can check temperature, especially with a degree of neuropathy and not being able to feel, sometimes not being able to see. And I think it's important that we take that message home and how we can use technology to better care for the patients, giving them autonomy and some of the onus on them at home. That being said, I think we all need to do a little bit of a stretch, so no pressure ulcers are being developed. So stretch, bathroom break, coffee. I would say everybody would please come back here by 10:45. Thank you. Okay, welcome back for our round two. And as we're getting ready for our next speaker, again, I want to thank everybody who has participated, especially our host, Dr. Byerly, and the School of Medicine for having us here. It's been a really great turnout. We have a lot of people streaming and our donor who is out there watching with his wife. And so we want to continue this on and then have a conversation. So as you are sitting there refreshed from your stretching and some coffee, well, maybe not so much coffee out there, start thinking of some questions that you had or comments that you can share with us as we bring our panel for the closing end this morning. So I'd like to bring Dr. Morgan Jeffries here, the Associate Medical Director for AI, also a neurohospitalist, looking at AI, looking at the past, present, and future, and the platform within orthopedics. Welcome, Dr. Jeffries.
Can you hear me okay? Cool. Okay. So hi, I'm Morgan Jeffries. Thank you for the kind introduction. So today I'm going to be talking to you about artificial intelligence, looking at past, present, and future platforms in orthopedics. Okay, so here's the actual agenda. I'm not really going to be talking to you about cool things in AI that are coming to orthopedics because you've already had a good lecture on that. What I really want to do today is kind of talk to you about AI in general, and maybe define some terms that you've heard, but you're not really sure what they mean or how they're related to one another. And then, very importantly, I want to give you a kind of framework for understanding what makes a good use case for AI and how you can operationalize an AI model. So overall, really want to make you more informed consumers of AI. Okay, all right. So first off, a lot of the terms on this slide you've probably heard before. Artificial intelligence, machine learning, how are they related to one another? Well, artificial intelligence is kind of the biggest overarching term. There's not a great technical definition for it. The best definition that I've heard is cool stuff that computers shouldn't be able to do. So if you see a computer do something and you're wowed by it and you're like, oh, it seems intelligence, that's AI. Later, you may be over it and you stop calling it AI, and that's fine. Artificial intelligence includes things like rule-based systems, so expert systems that are based on decision trees like if, then. But also within AI, and more interesting, is what's called machine learning. So what machine learning is basically, instead of explicitly programming rules, you give it a bunch of data and it figures out what those rules are. So most of you are probably familiar with linear regression, just fitting a line to a bunch of data points. So let's say that you have you want to predict housing prices, and you have a bunch of data about houses. And what you would do is basically you would give all this data about houses to this algorithm, and then you would give it along with that what are called labels, which in this case would be the actual housing prices for the data set that you're training on. And then basically it would come up with a line, and then later on you could use that line, that formula for that line, feed in more housing data, and have it spit out a predicted value for the house. And if it's done a good job training, what will happen is that value will be close to the actual price of the house. So that's the fundamental idea behind machine learning. And then so machine learning, besides just linear regression, includes things like logistic regression, which is similar to linear regression, except it's for classification tasks, and things like decision trees and various other algorithms. But one of the most important subsets within machine learning is what's called neural networks. And neural networks basically are a kind of machine learning algorithm where the architecture is roughly based on the brain. So you have this concept of units arranged in layers. Within that, you have what are called deep neural networks, and you may have heard the term deep learning before. And deep neural networks are basically just neural networks with a bunch of layers. So most of the breakthroughs that have come in the past 12 years, since about 2012, have been in deep learning. So things like the advances in computer vision, advances in natural language processing, and more recently, a lot of, well, really all of generative AI falls under that. Okay, so how do machines learn? There are basically three broad paradigms. You have what's called unsupervised learning. And unsupervised learning basically is you give the algorithm a bunch of data without those labels, so like the housing data without the prices, say, and you have it find patterns. So things like finding clusters of data that fit together, or finding outliers within the data. Then you have what's called supervised learning, and supervised learning is really just what I walked you through before with linear regression. That's a paradigmatic example of supervised learning. You're giving it a bunch of labeled data and having it come up with some prediction for new data that comes in. And then you have what's called reinforcement learning, and reinforcement learning is basically you're trying to train a model to do some kind of tasks. It usually is like a multi-step thing. So things like game playing, like AlphaGo, or like learning about protein folding, models that do protein folding predictions, or things like self-driving cars, that all falls under reinforcement learning. So out of these, the least important one, the one that has had the least impact, would be unsupervised learning. And the one that's had the most impact is supervised learning. And then reinforcement learning does have some impact. Obviously, self-driving cars are pretty important, but it's less so than supervised learning. So the boom in AI, and by the way, through this talk, I'm going to be talking about AI, and when I use that term, I'm mostly going to be talking about machine learning. So just I know they're distinct, but don't be confused. I'm still mostly talking about machine learning when I say that. So the boom in AI in the past decade plus has been fueled by data, and specifically labeled data, because most of it is supervised learning. So where do all these data come from? So there are a bunch of ways that you can get labeled data. One is that you can collect it yourself. You can either mine data that you have, like we do this a lot in healthcare. So you go through the EHR and you pull data out, examples of patients who have whatever condition of interest, and you pull out a bunch of information about them, and use that for your training data. That works. It can be pretty time consuming. Then you have public data sets. Those are great if they're available. They're not always available. For a lot of problems, they're not. You can also do things like collaborate with other organizations, kind of pool your data together, or in some cases you can crowdsource the work, so you can have a bunch of people do your labeling for you. And then there are a bunch of advanced techniques that you can use so that you can reduce the amount of time you actually have to spend in labeling. The reason that collect it yourself is highlighted here is because really within healthcare, that is most of what we end up doing. It's mostly a lot of collecting it ourselves, usually through data mining. Okay. So yeah, lots of hype around AI. And this quote on the left is from a guy named Geoff Hinton. You may or may not be familiar with him, but he is a Turing laureate, which is basically like the Nobel Prize of computing. I guess he didn't actually invent backpropagation, but he popularized it and he did a bunch of other things. So this is something that he said in 2016, which is essentially boils down to, yeah, AI is getting so good at reading scans, we're not even going to need to train radiologists anymore. He's a very smart guy, and this is an absurdly naive statement. We're nowhere close to getting rid of radiologists. That's not happening in the foreseeable future. And the reason for that is that AI can perform really well in these certain sort of isolated tasks, like in the sort of limited domain. But it also has this tendency to stumble in areas where it's surprising. Like you would think it would be able to do something, and you end up it ends up failing spectacularly in some subset of cases. And when it makes mistakes, we can't just say, well, the AI did it, it's its fault. All those mistakes come back to us, which means essentially AI is a tool, and it's a tool to be used and supervised by human beings. So why do we get fooled by this? Like, why does AI sometimes seem so much smarter than it is? Well, one reason is that we've had a lot of legitimate breakthroughs, again, since 2012. So first you had big advances in computer vision, and then we've had a lot of advances in reinforcement learning, things like, all the self-driving car stuff, things like protein folding, and then more recently in natural language processing and generative AI. So there's a lot of things that you keep seeing you keep seeing all these really big advances, and it's like, yeah, demonstrably, it can do a lot more than it used to. But when we evaluate these models, we don't always give them, we rarely give them such a comprehensive evaluation. This comes up a lot more recently with large language models, which are increasingly called foundation models, where we have these benchmarks to say, like, how good is this model? And they sample like these small areas of functionality. For example, like you've probably heard people hype up like, oh, ChatGPT passed the USMLE. And that's great. I mean, that's impressive. It's better than not doing it. But it also doesn't mean that ChatGPT is capable in any way of practicing medicine. So you're seeing like these narrow areas where it's excelling. It's also, you can also get fooled because a lot of times the evaluation data has leaked into the training data in some way. So what looks like some new capability is actually it's just memorized part of its training set. So it's regurgitating an answer that it already saw, and it doesn't mean it's sort of generalized that capability. Another reason is that we don't really have a great intuition for where it's going to struggle. There's this idea in AI called Moravec's paradox, where the things that we think are going to be hard or end up being easy, and the things that we think are going to be easy end up being hard. There was this story of someone who got assigned computer vision, got assigned like vision as like a summer assignment. Like, yeah, you figure out vision for us. If you don't know as much about the history of AI, you wouldn't realize how ridiculous that is. But I mean, this was like 30 years ago, and we're really kind of just getting into the range where it's doing a pretty good job with that. And then the other thing is that, when we don't understand something, a lot of times we'll hear these confident experts, sometimes very smart people, talk about where they see AI heading or where they see its capabilities, what they think it's actually capable of. Like, for example, the quote by Jeff Hinton. We'll say, that guy knows a lot more about this than I do. Maybe he's right. Okay, but what is AI actually good at? Well, it's good at a lot of things, but broadly, it's very good at recognizing patterns in data, and it's also good at generating data. It's very good. It can be single-minded in ways that we can't. I mean, it's not practical for us just to sit in a room and do one task over and over for the rest of our lives, but for an AI model that's dedicated to a certain task, like finding pneumonia on chest x-rays, that's the only thing it ever has to do. So it can be really good at it. And it also can work without fatigue. That's something that humans can't really do. It's kind of so-so at reliability and complex reasoning. It depends, if you have just like a predictive model doing something like, finding pneumonia on chest x-rays or whatever, and your data aren't changing very much over time, it can have pretty consistent performance. But if your data do change, it's probably going to get worse. And then, also within the realm of foundation models, that's one of the big problems that we're facing is like they can do a task one time, but you can't get them to do it well consistently. So this is kind of in that in-between area. Complex reasoning, sometimes models look like they're doing a good job of complex reasoning, and then it turns out they've actually just memorized part of their training set. So they may see, you may give them some kind of like brain teaser type problem, and, they can handle it. But then if you do some minor variation on it, where that answer no longer makes sense, they'll just kind of regurgitate the answer to the brain teaser because they think it's like, oh, I know this one. And then what are they bad at? Flexibility, learning on the job, and learning from a few samples. So let's say that you have a radiologist who's trained to read, musculoskeletal CTs, whatever. If you get a new scanner, it's pretty much a foregone conclusion that they will be able to adapt to that. They may notice some subtle differences in the way that the images look on the new scanner compared to the old one. This came up, we got new scanners, and I remember one of our radiologists saying, like, yeah, the vessels look smaller on this one than they did on the old one. So they'll adjust their reads accordingly. So humans are good at learning on the fly like that while they're doing the job and learning from just a few samples. And for an AI system, you absolutely cannot assume that. If you have a model that's trained to read studies or identify some finding on particular studies, if you get a new scanner, you absolutely cannot assume that it's going to be able to continue to do its job well. You have to test it, and then you may have to retrain it. And when you retrain it, you probably have to provide a lot of samples. Just an extension of that idea of models not being great with change. These are two sort of more specific applications of that. So one is if you have a model that's been validated on like some kind of external data set, you might hear great performance numbers and think like, yeah, this should work on ours. You really can't assume that. Your data may be different from the data that were in that data set on which it was validated, and you actually have to check. That's called local validation. And then the other thing is that your model, your data may change over time, like, for example, if you get a new scanner. But there are lots of reasons why it can change over time. So you have this phenomenon called model drift, where the performance just kind of can get worse over time. And so you have to monitor that on an ongoing basis. Okay, there are a lot of risks involved in AI, and governance is largely aimed at identifying and mitigating those risks. I'm going to call out the one in the bottom right because it kind of factors into something I'm going to talk about later on, which is how you can operationalize models and fit them into a workflow, and that is automation bias and de-skilling. So if you're dealing with an automated system and it's doing a pretty bad job, you'll kind of tend not to trust it that much, and to the extent that you do, you'll be really careful about checking what it came up with. But as the system gets better and better, more and more reliable, you tend to check it less and less. You just put more and more trust in it. And the problem with that with AI is that it can fail spectacularly at some point. And a really extreme form of that automation bias, or what can happen as sort of an end state of that, is that you can actually get less good at the job that you were doing before, so that if it's looking for some kind of subtle finding on whatever imaging study, you may just get less practiced at doing that. And so when it's time to check the model's work, you're like, oh yeah, I'm not really sure if that's real or not. Okay. All right, so moving on to the second section of the talk, this is use and evaluation. Okay, so where do we actually see AI used in healthcare? So three kind of general places. The place where you see it used overwhelmingly the most, right now at least, is in predictive models. So predictive models are trained through supervised learning, and they come up with predictions. Linear regression, again, is an example of predictive modeling. There's two kind of general forms, which are regression, where you're trying to predict a value, and then classification, where you're trying to apply a class label. Again, this is really where we see most of the applications in healthcare, current day. And of those two, really, classification is the more important. And then you have generative models, which are something that we're just starting to work with now. An example of that would be like ambient listening technology uses generative technology. But things like summarizing answers, summarizing and doing question answering over a set of documents, that's another example, translating text. And then on the far right, you have what are called agents. And this is really, this is not something that we can really put into practice today, but this is really where a lot of active development and research is going on. So the idea behind agents is basically these are models that can interact with the environment and make decisions. And so if you have an agent that works well, you can actually automate a lot of tasks end to end. Again, reliability is a major issue here. Okay, so when people think about AI, a lot of times they think about just the model. Well, actually, if you want to deploy AI, if you actually want to use it in the real world, the model is a pretty small part of that whole system. So you have to think about things like, where are we going to get our training data? How are we going to test this? How are we going to measure performance? How is this going to be introduced into a workflow? And a lot of other things. So most of the work is actually not in building the model. It's not, most of it is not the model itself. It's the things surrounding the model. When you do have an AI system, skip? Oh. Weird. That slide got out of order. I apologize. I don't know how that happened. Anyway, so when you're thinking about an AI solution for a problem, there are some questions that you're going to want to ask. So one is there a well-defined problem to be solved? You don't want to just have some kind of vague notion of, I want to do this thing. You want to get pretty specific. An example that I'll introduce later is detecting missed fractures. If you're saying, we're missing fractures and we need to do a better job of detecting them, that's not specific enough. You want to really drill it down to, well, I want to make sure that we don't miss any fractures coming out of the emergency room. Or you can, it could be broader than that, but the point is that you want to be as specific as possible what exactly you're trying to do. Where will AI fit into the workflow? Who's going to see the output? What format is it going to come in? What do they do with that information? Is this something AI can do? I'll just say that sometimes if people have come to us with requests for things that it's really beyond the current capabilities of AI, So you want to have a general sense of what's realistic and what's not. I mean, one example, somebody said, maybe we could have it, scour the literature and find when there should be updates to our stroke policy. Yeah, that's not realistic, in this day and age. And within that, another question would be, do you have the data available at the point in time when you would need to get whatever information out of the model that you need? So, if you're relying on, for example, something that abstractors come up with after the hospitalization, as one of your input point or one piece of your input data, you're not going to be able to use that during the hospitalization to make any kind of predictions. How are you going to measure performance? When you're measuring performance, there's two sort of parts to that. One is looking at the performance of the model itself, and one is looking at the performance of the system. So how well is the system solving this problem that we're trying to solve? Is there a workable solution that doesn't involve AI? AI is complicated. So if there's something that you can do that doesn't involve AI, that's probably going to be simpler and more robust in long term. And then what else do you need to make the solution work? If you just need AI, great. But if you need AI plus 10 new hires to make your solution work, that could be a problem. I'm going to have to jump back to one of our previous slides when we get to it. Okay, so some more specific workflow considerations. What actions are going to be taken based on the outputs? So when you think about this, a lot of times when you think about AI and how we're going to use it, in practice, you'll think about the model will tell us, there's sepsis present or not, and so you can, look at that information, and if it tells you there's sepsis, you can act on that. But you really have to think also about what happens in those cases where the model's wrong. So a lot of times it'll, fire a sepsis alert and there's no sepsis. In the cases of sepsis alert, that's kind of just a minor annoyance, but there are other cases where people might take actions on that basis that would be potentially dangerous or costly, and you really have to think about that when you're considering, where this is going to go on in the workflow. Will humans have to evaluate the AI output? Sometimes you have systems where humans that are getting that AI output can just accept it as sort of true, but other times that's not the case. So, for example, ambient listening. If you have an AI scribe that is taking notes on your patient encounter and it's giving you a note transcript, you need to review that to make sure that it's accurate. If the people are going to be having to do that, do they have enough information to judge whether or not it's correct? And is that actually going to be easier for them than just generating the answer themselves? So in the case of AI scribes, I think the answer is yes, they do have enough information because they were there in the encounter. And yeah, it's definitely a lot easier to review a note transcript and say, this is correct, maybe I should edit this, than it would be to generate it from scratch. Typing's terrible. And then lastly, and this one is going to be more of a concern as AI becomes more and more capable, is do I want AI doing this job? So I talked to you before about the risk of automation bias and de-skilling, but there are also things that are sort of essentially human that you're going to want to have human beings there for. So if you had an AI model that was good at having conversations with patient families about end-of-life care, goals of care, would you want to use that? That really seems like something that a human being should be there for. So you need to think about, is this something that I want AI to do? Okay, I'm going to back up here to this. When you're evaluating models, you want to think there's two parts. You're evaluating the model itself, and you're evaluating the system as a whole. So in evaluating classification models, there are a bunch of different metrics that you can use. For the sake of time, I'm not going to spend a lot of time talking about this, but I will say, you can't assume that because it does well in one of these that it's going to do well in all the others. So, sensitivity is one that we're familiar with, specificity. And we often hear those because those are useful in a lot of settings. They're sort of independent of the prevalence of the condition of the population. But in some cases, that's actually pretty important. So positive predictive value is one that can be very important when you're evaluating a model's performance, but that depends on that prevalence within the population. So if you have a condition, that's exceedingly rare, you may have a model that does a great job of discriminating in general, but still most of the time that it tells you that a condition is there, it's going to be a false positive. And depending on your application, that may be a bad thing. On the far right there, you have that URL for an interactive visualization. So I built this with Claude. Essentially, if you want, you can go there and play with this. It can help you develop an intuition for what all of these different performance metrics mean. There he goes, getting the QR. Okay, that's enough about that. All right. So when you're thinking about the performance of the system, there's more than just the model. There's the system as a whole. And when you're talking about the system as a whole, you're going to want to look at what problem you're trying to solve. So depending on what problem you're trying to solve, that'll help determine what performance metrics you actually want to use. And these are just sort of broad categories of those. You might look at clinical outcomes. You might be looking at operational efficiency. We're too slow at doing this thing. Look at it, what our times are and see how they change when the model's implemented. User experience, that's a big one for a bridge, or economic impact. And so the choice is going to depend largely on what problem you're trying to solve and also how easy or difficult it is to gather those metrics. Okay. These next two slides are this is really like the heart of this talk. So if you can get from these what the challenges are here in terms of operationalizing these models and also understand why one of these is arguably a better use case than the other, you will have absorbed the most important lessons from this talk. So when I was researching this, when I was told we want you to talk about AI and orthopedics, I had a couple of review articles that I looked through, and one of the use cases that they talked about was fracture detection. So fracture detection is supposedly an important problem. I am not an orthopedist. I don't really know how important of a problem this is. I can see where it would be bad if it happened. I don't know how often it happens. But basically what this article had was, yes, it's an important problem, and one of the articles mentioned a model that had a sensitivity of 92% and the specificity of 91% of detecting fractures in plain films. Okay, so those numbers sound pretty good on the surface, but there are some important questions to ask about those and some important things that we kind of need to think about. So first and foremost, you need to ask, what is the human baseline for detecting fractures? So here's why this is important. We're trying to detect, in this, the problem that we're proposing is we're trying to find missed fractures. So we really are interested in the cases where the radiologist looked at a scan and said, no, there's no fracture here. So what we're actually interested in terms of performance of the model is not how it does on that whole set of images. We're really only interested in how it performs on that subset of images where the radiologist said, there's no fracture here. If the radiologist is good, well, if the radiologist is not very good, then there'll be a mix of, there's going to be some fractures in there, and there'll be a lot of things that actually aren't fractures. But the better the radiologist is, the fewer actual fractures there will be in that subset. And more than that, if they're really good, the harder and harder it will be to find those fractures because they're going to see all like the displaced fractures and the really obvious ones. So you'll start to get into things like these hairline fractures where it's like, I got to squint at this, but I think it's actually real. So the model will actually have to be finding the ones that are at least hardest for a human to find, and they'll have to be pulling that out of a pool that contains almost none of them. And again, if that condition is very rare, like if it's looking at just that subset where the radiologist has already kind of depleted that of all the real, or of most of the real fractures, he's going to be dealing with this smaller population where there are almost no fractures, which means it's more and more likely that when it flags a fracture in that subset, it's more and more likely that that's going to be a false positive. And so that also will, that not only does that make it harder for the model, it also means you're going to have to screen more and more of these in order to make any kind of difference whatsoever. Because if they're missing a ton of them, then you have lots of opportunities to catch fractures. But if they're missing 1 in 1,000, it's going to be much harder. You're going to have to screen way more. I'm not going to do the math on that, but you're going to have to screen many, many more studies in order to make any kind of impact. Okay, but let's assume now that you actually have a model that you think works pretty well and you want to deploy this somehow. So where do you actually put this into the workflow? Okay, so there are several places. The most obvious one is to give some kind of notification to the reader. That's the most obvious one. Is that good though? So first, when you think about this, again, you tend to think of, well, this is, there's going to be cases where they miss it, and then the AI will be there to remind them that, yeah, there actually is a fracture, and they'll look a little bit harder. You really do need to think about the many, many cases where the model is going to be wrong and how that's going to impact things. So what will be the effects of that? Well, one case, I've actually seen this happen, by the way, not with fracture detection, but with aneurysm detection. The radiologist may get a notification that, oh, the AI found this significant finding. I'm looking at the study. I don't see it. I think you should order another study to look again. So if the radiologist gets a bunch of messages saying like, oh, the AI found a fracture, and it's like they're staring at it, and they don't see it, they may say, I don't know, get a CAT scan. So you may actually end up getting a lot more CAT scans on patients, maybe way more than you need. That's something that you should keep in mind. Another consideration is there's some evidence to support this idea that if the model isn't performing well, it'll actually drag down the performance of the radiologist. So they'll get less and less good at reading. And that's something that you should also keep in mind. And then the third thing, and this is pretty important, I think, is that once you deploy a system like that, there's really no way for you to know how well it's working. So you're trying to catch fractures that the radiologist missed, that presumably the unassisted radiologist missed. Well, there's no more unassisted radiologists now. You only have the AI-assisted radiologist. So you have no way of knowing what they would have caught without the AI's help, which means you're really kind of flying blind in terms of like, is this doing anything for us? Do we need to maintain this costly system anymore? So what's another way that we could do this? Well, another way is that you could use it for triage. We actually do that. We have a system that that looks for blood on CTs, head CTs, and if it finds them, it bumps those to the front of the radiologist's queue. So that's kind of nice because the radiologist doesn't really have to consider the truth or falsehood of the thing. They have to read all the studies anyway. So they just get a study and it's the next one on their queue and they read that and they make their own decision about whether, what the findings are. The problem with that in this case is that the problem that you were trying to solve is missed fractures. Triage will bump things up to the front of the queue, which depending on the setting may or may not be important. Maybe in the outpatient setting, you wouldn't want to delay too long in finding a fracture, but I think for like ED patients, maybe that's less of a concern. But fundamentally, it just doesn't help you solve that problem. They're not going to necessarily find fractures that they wouldn't have found just because they're reading it sooner. So then the third way that you could consider doing this would be to flag it for secondary review. So think of it like this. Basically, like you have a radiologist and then you have a model, both independently looking at the study. And the radiologist comes up, they do their read, they come up with their impression. And then the AI separately reviews it and says fracture, yes or no. If the radiologist says there's a fracture, well, then you haven't missed a fracture. You may have overcalled a fracture, but you haven't missed a fracture. So you don't need to do anything extra in that case. If the radiologist says there isn't a fracture, then you could look at what the AI says. And if the AI says that there's a fracture, you could then send that to a second person for a secondary review. That actually kind of makes sense. I think if you were going to operationalize this, that's probably the approach that I would advocate for. There's still some issues with this. There are still some challenges here. So one is, who is that second person? It may be, maybe the person that read the plain film the first time and said there's no fracture was your best radiologist. And they've got tons of experience and they looked at it and they're like, yeah, somebody could fall for this, but actually that's artifact. And the AI, in fact, falls for it and says it's artifact. And then it goes for secondary review to some more junior person who also falls for it and says there's a fracture. And so it winds up being classified as a fracture. Again, that may or may not be a problem. It may be, that you catch it later on, figure out there's no fracture, we don't need to do anything else, but it's a consideration. But another thing is, like, how do you have enough people even to do that? And then ideally in a system like this, what you would want to do is have the second person who's reading it be blinded to the AI's output. But let's say, you may not have two people reading plain films for musculoskeletal on the same day. So let's say somebody, I don't know how they divide up their work, but you might have somebody reading like CTs, for example, and then another person reading plain films. And so the person, who is reading the CTs might be the backup person to, overread these studies if the AI, if there's a discrepancy. Well, if they know how the system works and they suddenly, amongst all their CTs, they get a plain film to review, they're going to know, oh, so clearly the AI found a fracture and my colleague did not. And that also is going to influence what they say. And then there's some other smaller things, but still important would be like, how do you reconcile the reports? Because if two people are reading them, they're each going to enter their own report. So, which one do you go with? Is there some way to? That's probably not a good way to merge those together. So, this is something that in the literature, I mean, there are a lot of people working on this, but it seems pretty challenging to build a system that would be useful around this problem. Now, I want to contrast that with this. This is a system that we have deployed right now. It's obviously, this is not an ortho. But it's around colon cancer screening. So colonoscopy is recommended for patients 45 and older. Not everybody gets them. We have a lot of people who aren't up to date on their colonoscopies. So we have care managers who basically have a list of those people, and they can do outreach. Well, there are something like 45,000 people on that list. So it's a lot of outreach. So how can we maximize their efforts? And basically, there was a model that was built, and that model tries to identify patients who are at higher risk for having a significant finding on their colonoscopy. And the model actually works, well, much better than the baseline. So if you just look at the patients who were unflagged by the model and how many of them had, had a significant finding in their colonoscopy, it's only about 0.6%. But if you look at the ones that were, flagged by the model, they have 6% of those, roughly, have a significant finding on their colonoscopy. So, 10 times more people. So the outreach efforts are basically 10 times more effective. Now, why does this work well? Well, one is it's an important common problem. Colon cancer is the #2 cancer killer in this country. And this, I don't know how accurate the statistic is. I found this from some kind of public health website. But the majority of them are thought to be preventable through colonoscopy. It's also something that you couldn't have a human being do. So there's no practical way that you could have human beings go through 45,000 charts and assign risk scores to those. There's just no way to do that. But another big thing is that the baseline is so poor that even a model that doesn't work all that well is just vastly superior. So if you're just looking at the rate of significant findings for regular screening colonoscopies, because without the model in place, it would be slightly higher because you'd have both of these pools mixed together. But still, I calculated it out, it would only be like 0.8%, so fairly low. But with the model, then it's 6%, so it's a good 8 to 10 times as high as that, what would be that baseline. So 6%, if you think of the model as predicting, actually not just high risk, but actually predicting there will be a significant finding, 6% positive predictive value is pretty poor. You wouldn't really brag about that. But the baseline is so bad that is just vastly superior. And so that's a really exciting thing because, we found this problem where it's like, yeah, it's almost impossible to screw this up. So when you're thinking about ways, that you can operationalize AI, I want you to think of this kind of example of what's a thing that AI could do that a human couldn't possibly do, where it's being done so badly right now that just any improvement would be a big jump. Okay. No talk on AI would be complete without talking about generative AI. Most of what I've really been talking to you about, because most of what's employed in healthcare today is, predictive modeling, really specifically classification. But things are changing. So, 2 years ago, just short of 2 years ago, ChatGPT was released. Everybody got super excited about it. And there was, a bunch of people tried it. I think far fewer people stuck with it and continued to play around with it. ChatGPT, like the original version, 3.5, with none of the bells and whistles, is fun. It's not super useful, actually. When they released 4.0, that was a more useful model, but still, there are a lot of things there that work kind of, sort of okay. Most people don't really necessarily, for most applications, it's not really practical to just copy and paste things into into a chatbot and say, can you do this for me? And I'm going to feed in this giant prompt that tells you exactly what I want done. What you really want is more of like a product. Like you come up with a good use case, and then you have just a tool that does specifically that and nothing else. You don't need like a full chatbot that has all this flexibility. You need a thing where you click a button and it just solves your problem for you. What we're starting to see now is more of that kind of thing. You're starting to see this transition from having just this fun, promising tool into actual products. So we are piloting a bridge that has just started, was it 2 weeks ago? Yeah, 2 weeks ago. And people are really excited about this. So like within healthcare, I mean, there's definitely a lot of hype around generative AI, but people use these tools and really love them. So there's real value here. But there are a lot of other things that you're starting to see. I don't know how many of you use these tools. I use Claude like a lot. Claude Artifacts is great. I used it to generate this graphic here. I also used it to create the single-page web app that does the interactive visualization of classification performance metrics, which when you see it, it looks pretty cool. And Colab was able to do that all on its own without really very much from me other than just kind of general design specs. ChatGPT now has advanced voice mode. If you've played around with that, the transition from having to type all of your questions in to being able just to click a button and talk to it and have it respond in a human voice is pretty nice. I mostly use Claude, but I've started using ChatGPT for just some kind of like one-off questions, things that would be ordinarily, even that would be like ordinarily a Google search. I might start with that just because it's so easy to access and it's much easier than me typing a bunch of stuff in. Google's Notebook LM, this is pretty fun. You can podcastify anything. So basically you can drop in a document and it will generate a very realistic sounding podcast out of that, where two people are having a conversation around whatever the thing is and asking each other questions about it. I debated including this as an example. It's a little churlish, but it was somebody fed it a document that was, I think, just the word poop over and over again, and they got into a discussion of Dadaism. Like why is it that we want to project meaning on this thing? So it's pretty impressive. But we're like in the early days of the internet here. So I'm looking at all the young faces. I'm like, you guys have no idea what I'm talking about right now. There was a period called the 90s, and companies came out and like their whole valuation was based around them having .com in their name. They would just do stuff that you didn't need to be on the internet to do, but they were just like, we're whatever, .com. And they would have like these massive valuations, and then it all just tanked in 2000. And a lot of people were like, it's overhyped, nothing's ever going to come of it. Okay, obviously the internet has a major impact on our lives. I mean, it's really, it's sort of a trifling thing to say. It's like, yeah, of course it has a huge impact on our lives. What would we do if it just suddenly went away? We don't really know if AI is going to have that same level of impact. I mean, that's a huge impact. But I think we're still in the early days, and as you see these products coming out that are actually doing useful things, it gives you more and more hope that, yeah, I think we actually will be able to build some useful stuff here. And the technology is going to keep advancing as well. So, there's going to be, the technology gets better, but also we get better and better at identifying those use cases that really make sense for this technology. Okay, so just final points. AI is not magic. It's technology. It has its strengths. It has its weaknesses. And it's something that is there for us, and we have to supervise it. Operationally, AI is a challenge, but it's very important. If you can't do that, then your model's just going to sit on a shelf and not really solve any problems for you. And the future is exciting. And probably most importantly is we really need leaders in this space, which means we need people who understand the technology but also understand the domain. And so, I'd encourage you, all of you, when you can, to get out and try some of these things and really start thinking about them, because we don't want to be in another EHR situation where somebody else is steering the ship. It's really much better for all of us if we have people who are capable, who can help guide the direction of this technology. So, Last thing, I just want to put in a plug for Geisinger's new AI Hub. This is a work in progress, but basically it's our home for AI on the web. You can go there to get an overview of the kind of work we do. It's also if you want to submit a project request or if you want to learn how you would work with a vendor who uses AI, you can get information about that there. We'll also increase, and we have some educational content there, but that amount will be increasing over time. So it's very easy URL. It's just ai.geisinger.edu. And that's it.
Thank you so much. So I want to bring up our next speaker, and while she is coming down here, I wanted to focus on one of the key things that Dr. Jeffrey said about operationalizing AI and really looking at it in our own domain, where we are focused. How can we make it better? I already started kind of wheels were turning in thinking about how do we capture those patients who may go, like you said, with the fracture care, the front of the line to be triaged faster, looking at our high-risk patients with diabetes who may be out there and thinking, they were canceled, they missed an appointment, they really don't need to be there, but how can we use this as a tool to optimize capturing those patients to reduce the mortality and also the limb loss. And then user experience. I think that was a really key point that you brought in, and that speaks to a bridge that we are, piloting. The podiatrist who's going to be using this, I'm very excited, but what I've been learning and gathering, especially from my surgical colleagues, both in podiatry and orthopedics, is that a bridge as a ambient dictation tool, may be more beneficial, and we'll find out as we go through this, for family medicine, or in my practice where we are doing more of the dialoguing and we don't have maybe many of the extenders or the surgical arena. So again, user experience, the input, and like you said, you put a plug in that we all need to be immersed. So kind of connect with your inner nerd, myself, the learners that we're talking about, and really trying to use this in your own arena. So with that, we will bring our next case study up in, okay. So we have Dr. Lawrence. She is a PGY1 in podiatry, and she is bringing The Pressure is On, application of digital thermography on long-term TMA outcomes, again, wearables in AI. Thank you.
Thank you for that great introduction. I also know I'm the last presentation before Q&A, so I'll try to keep this succinct. As they said, my name is Zaria St. Lawrence. I am a PGY1 from the podiatry program down here in Scranton, and I'm presenting on one of our TMA cases that we had. Okay, cool, it's working. So just a brief overview of my session. We're just doing the case presentation, what complications you'll see in our TMA patients, as well as a literature review of thermography and what technology currently exists for it. So just a preview of this patient, there's not a lot of capture for this one because they started outside the Geisinger system when we first saw them in 2019 through the ED, and they were brought back to the Geisinger system in 2021. So a 55-year-old male presented to the emergency department due to right foot redness and swelling. He had 3 weeks where he self-triaged himself. He called his primary care physician. They gave him 7 days of Keflix. It got more swollen. Then they were like, he's like, oh wait, I have Bactrim from like a week ago. Let me go get that. Self-triaged it there. Then finally presented to the ED in April of 2019, my mistake. Result and had bloody drainage, redness, and swelling in the area. The patient is a type 1 diabetic and sensate and had no recollection of any injuries prior to this. The patient also lost about 25 pounds over 3 weeks and was like, it's not that bad. So relevant history, the type 1 diabetes, the peripheral neuropathy, the hypertension, and the hyperlipidemia. Prior to this, no surgical intervention on the foot or ankle, 25 years history of smoking, and had an allergy to statins, but during physical exam, full range of motion was assessed, patient had palpable pulses, so we weren't truly worried about anything but the infection that was on the distal phalanx. So the first surgery that was performed was July 20th, 2019. There was a distal sinus amputation, which is just taking the distal phalanx, clothing the toe. They came back positive with the blood cultures right after, so that we discharged them on the PICC line. Procedure had no pain. no postoperative complications of note, and they were still seen by their podiatrist outpatient. Somewhere along this line, wound care starts to fail. You see the flap in the toe necrose, and they were sent to the PCP to be brought back for it was supposed to be a transmetatarsal amputation. How we escalated to that, I'm not 100% sure. So they were seen by their PCP. The blood pressure was 90/60, and they were tachycardic, so they were sent straight back. So they underwent a hallux amputation for infection control, and now it's getting worse. Pre-scheduled for that TMA 2 days later, so they ended up going for where they're like, please don't do the surgery right now. We just want to take a little bit of toll and let me get stronger before we do anything else. So it became a stage procedure where we did the partial first ray and then transitioned to a transmetatarsal amputation. So it was roughly 3 days difference between the two surgeries. The first bone culture came back right before the TMA for enterococci, and they were discharged on a PICC line again, continued to follow up with outpatient podiatrist. Within a month, the TMA still has signs of infection, necrosis. ABIs were double checked to be 1.2. They had healing potential, and vascular was looped in at this point. Their A1C had jumped up from 7.6 to 11.4 in those 3 months, however, so more chance of dehiscence and necrosis. And then when we did the third surgery back in August, we found that there was a clean margin within the surgical site. So they were then treated. TMA went well, no tendons Achilles lengthening. Patient was following up and then recaptured by Geisinger in 2021. So there was callus to the stump due to tendon unbalance, because one of the side effects of a TMA is you lose a lot of your everters from losing the distal connection. The Achilles tendon contracts pretty much. So you see the callus on the top, and you also notice a forefoot varus for the top of the foot as well. The wound was painted with betadine because it was only macerated. It wasn't probing to bone, no malodor, no sign of infection. Patient resumes home health, and we instruct them to do the changes daily and follow back up in 3 weeks. This is the point we lose the patient for capture again, and then we don't see the patient until 2023. 2023, the patient comes back with a callus but no wound. It's pretty much on the near the fifth metatarsal. They've had this since the surgery, so this has been roughly 4 years at this point, and states that they haven't been able to walk. So based off that evaluation, we know about the Achilles contracture causing the forefoot to go into that varus position. We know that the patient's in an extreme amount of pain. They don't really have the quality of life, and that's the whole purpose of limb salvage. Give the person a better fighting chance. So rather than proceed to a proximal amputation, we decided to do a tendo Achilles or gastrocnemic recession because the patient had equinal varus. We lengthened the anterior tibialis tendon, and then we also did a revision of the fifth met. So this is some of our postoperative outcomes for the fifth and final surgery on this foot on March 16, 2023. So right plantar foot wound was excised and debrided. The tendo Achilles was lengthened, and that gave us a little bit of more motion, and the tibialis anterior tendon transfer happened, which is specific to us. So what the tibialis anterior transfer, it has 3 small incisions. You take the tendo Achilles, the tibialis anterior, you split the tendon a little bit and you reroute it to the lateral aspect of the foot. It takes off the inversion force on the foot, so you don't have the foot as much in varus, as well as allows you to deal with the callus, which when we do the post-op visit, we saw that the patient still does have the callus, but it's not painful. They're walking, they're able to use a CAN boot, and actually be able to use the limb again. The patient would later die of a stroke later this year. So this is a summary of our surgical interventions for this patient. We started off with a right hallux Symes amputation, only taking the distal phalanx, and progressed to a partial first ray. Roughly about 3-4 months later, we go to a transmetatarsal amputation, and then we have to revise it due to reoccurring infection before we finally see the patient again and do a tendon balancing to try to help the contracture from the Achilles tendon pull. So what lessons are in this case? 1, limb salvage is a journey. The tendo Achilles wasn't conducted originally, which led to more ulcerations later on, and it led to skin breakdown. Patient follow-up and education are essential because this patient was a type 1 diabetic. He had had diabetes for 30 years, and he started struggling with control later on. So patient education and being able to follow up on them really mattered in this case. And patient compliance can make or break the salvage, because the patient up until that last surgery was still a smoker. So you're still at risk of vascular compromise at that point. So the salvage still has the potential for failure. So now I'm just going to highlight some of the complications of TMAs and the literature review for the digital thermography. Just because the podiatry program does do a lot of work on this, one of our recent projects was how hemoglobin A1C as a predictive value for transmetatarsal amputation outcomes. So we had a 51% return to the OR for more proximal amputation out of 283 TMAs, so that's roughly 142 patients who had to go back for a BK or more. And the average A1C for those patients was about a 7.7, but we didn't find a significant correlation between the A1C and complications. Further research in the last 5 years, because historical podiatry data shows we end up with a proximal amputation, which negatively impacts the patient's life anywhere from 30 to 60% of our limb salvage predictions. So when we look at it in the year 2023 with Surratt et al., out of the 233 patients that they had to do TMAs on, they had 48.1% or 112 patients that had to get more than just a TMA. In Harris et al. In 2020, TMAs would subsequently require at least 9% of them needed more proximal 21% needed more proximal amputations, with most of them retaining the metatarsal base at 1 in most of it. For skin degradation, we had 24% requiring further debridement, while 37% having room for TMAs from Tan et al. In 2018. And then if you don't do the tendon Achilles, you're 35% more likely to get a wound compared to 3% more likely with the tendon Achilles lengthening. So that's also something for consideration when we look at how can we prevent our complication rates. I mentioned this briefly, but the contracture secondary to TMA is really because you lose all your distal attachments of your tendons, so like you get muscular imbalances. So this affects your weight distribution, you get more abnormal plantar pressures, and increased risk of soft tissue breakdown, and that's where digital thermography can come in. Digital thermography isn't new. It's been used in medicine since 1997, and it's simply the measurement of self-emanating infrared radiation that reveals temperature differences. So if you look on the pictures towards the right on A and B, you'll see there's increased temperature wherever an ulceration is. So we can use that as a predictive factor of how likely we are for a skin breakdown for a patient, or at least try to offload them prior to skin breakdown. And then in the Journal of Tissue Viability this was published June 29th, 2024. They did a systematic review without meta-analysis. They did more of a qualitative instead of quantitative study on it, highlighting the potential for thermography to be used for diabetic foot ulcerations. What they found of the 8 studies that they included from 1994 to 2021 was it did have a positive predictive value where they were able to predict more ulcerations prior to needing to do limb salvage procedures, and that it reduced the DFU burden in advanced patient care. So what modalities do we currently have? So similar to what Hari showed earlier, we have InTU pressure monitoring system, smart insoles, mats, pressure mapping systems, remote pressure monitoring platforms, all that have the capability to be integrated into Epic and other EHR platforms, which could help us have better outcomes. So these are my references, and thank you.
So while we are getting Dr. Branning up here, I'd like all of the expert panelists to please come to the front just to have a seat up here, and as we're transitioning. I will highlight again the learning part with what you were saying with transmetatarsal amputations and the offloading pressure. Dr. Parenti being a huge asset for us in podiatry and our diabetic patients in knowing way ahead and way in advance that the tendon Achilles lengthening for our patients, especially undergoing TMAs, was crucial in them not having that reoccurrence and really looking at a BKA. So I'm so glad that you highlight, and I like how everybody's speaking about AI. You know, it's been under our noses for so long, and I feel like because we are riding that wave, that hyperbole of, you know, excitement around AI, that maybe some of those tools that we had with thermography that people didn't use as much as they did before, or there was not that cost effectiveness, that now with AI it's more accepted and we can use them more often and integrate it to our patient care. So please come down to the front here as we prepare for our question and answer as we start the wrap up with Dr. Branning. So we'll just take 30 seconds for everybody to have a seat. If you see your name up here, you are up here. And if Kara is there, I don't know if she's going to be, let's see, bringing down, yeah. Thank you. Dr. Parenti? Okay, so we are at the wrap-up section, so I hope that you guys are also starting to think of some of the questions or queries or can you or what ifs as we have our experts here. I'd like to present Dr. Branning here, who has been my co-chair and also a fellow colleague in podiatry. She is definitely a mover and shaker, innovative in a lot of things, education, podiatry, and surgery. So I'm going to hand it over to her to start off the Surviving the Battle Against Limb Loss.
Such as the top one?
No,
This one?
this one, yeah.
Okay. So we've learned a lot today that we're in a battle against losing limbs. We're going to just go briefly talk about where we are right now in terms of our limb loss statistics versus limb salvage, and then show some applications that have already been occurring in the literature and in the industry to try to combat these statistics. So the good and bad and the ugly is that if you remember our opening slide with Arturo, at that time when that slide deck was made, it was at 50,000 amputations in the US annually. We're up to 73,000 amputations. The direct healthcare cost per amputee is $460,000, and the cost per hospitalization is encroaching about $19,000. So the scary part is that the rates of amputation and subsequent survival have remained stagnant over the past few decades. Now, an unaccountable, physician may say, well, that's because our baby boomer population is getting larger. Our patients are getting sicker. Our patients are getting older. Social determinants of health are a barrier and a burden to successful outcomes. But let's consider, in light of what we learned today, that it may be our slow incorporation or adoption of healthcare technologies. Our post-op morbidity and mortality of BKAs and AKAs still encroach about 25 to 40%. 1-year mortality, 13 to 40%. 3-year mortality, 35 to 65%. And our 5-year mortality, nearly 80%. And a lot of this just means that amputating limbs is not saving a life, nor is it saving a limb. So there's a lot of categories of limb loss. I'm not going to belabor this. These are all the factors that we deal with. Today has largely been the health-related factors. What can we do and do better to help to save limbs? So this is an agree or disagree. So these were two statements, is that the biggest challenge that we face with a complex limb injury is deciding the management route to take with a satisfactory outcome. Not good outcomes, not excellent outcomes, satisfactory outcomes. And someone brought it up earlier, is that a satisfactory outcome for the patient? It is, but often are we settling for a satisfactory outcome for ourselves? And then when we look at the outcomes of successful limb salvage versus a primary amputation in the lower extremity, there's no difference in the outcomes functionally at 2 years. So if we're limb salvage surgeons, how can we sit there and tell a patient and sell them on limb salvage when in 2 years they'd be no better than if they had an amputation? So can good and superior outcomes be achieved in limb salvage? I think all of us here would say yes. So then why are we still here? Why is the scale still 50-50? Why haven't we tipped the scale towards salvage? We know that cost-effective analyses conducted long-term have shown that salvage saves money, it improves functional outcome, but why can't we achieve it? And I think AI and a lot of the health initiatives that we talked today is the missing link. So if we're in a war, we should take up our arms with a lot of the things that we've learned about today, using data-driven initiatives, EMR efficiency, introducing wearables into our clinical practice, and AI integration. So these are 3 quick studies. This is the impact of limb salvage programs. We don't have a limb salvage program here at Geisinger, although we certainly have had engagement with, about 2 years ago, with some of our colleagues down in Washington. But the literature, the data demonstrates that comprehensive limb salvage programs reduce amputations by 36 to 86%, which results in an annual cost savings in the United States of nearly $26 billion. And then we're also saving CHS 36% and 86% respectively with salvage. Here's another example. This was an application of vascular surgery with limb loss using EPIC efficiency. And what they actually did is they did data mining. They were trying to reduce the length of stay and unplanned readmissions following amputation. And what they did is they actually calibrated the goals and they impregnated into their algorithm what they were trying to do. So they were trying to do a length of stay of less than 7 days and a readmission rate of less than 11%, which means that they, in this institution, would be performing better than the national average. And what they did is they told their, they searched for the records to identify patients not meeting the target goal, so people who were in the hospital more than 7 days and having a readmission rate of 11%. And then they had an actual limb salvage committee who reviewed the data every month. And what they did is that they would dynamically change their algorithm and they would dynamically change their treatment plans to help improve their own metrics. And they did that by instilling phone call visits, establishing patients at wound care, post-discharge, and also diverting non-urgent revascularizations to the outpatient setting. So here, wearables, again in vascular surgery. We can't let them be ahead of us. But again, they used wearables. And they actually used wearables to actually look at the, how functional and how active patients were after certain amputations. And they postulated that actually putting wearables on patients potentially before their surgery could best pair the right amputation to the right functional level for the patient, and therefore customizing amputation versus just a one-size-fits-all BKA for all. And then lastly, this is just an example, and I think Dr. Jeffries kind of touched on it, is that we already know what the poor indicators for outcomes are, right? We know rehospitalization, we know social determinants of health, people of lower socioeconomic class, patients with low self-efficiency, our diabetics, those who are already disabled. We can work through our orthopedic department and really find out what are the best AI-generated algorithms to devise patient-specific outcomes, which are sensitive to race or sensitive to social determinants of health, healthcare costs, comorbidities. Within our diabetic population, we could easily comb through our charts and have them detect elevated A1Cs as a risk factor for amputation, or just patients who haven't had their diabetic foot exam this year and be able to search through those charts and identify those patients. And we can provide transparency, which was already mentioned, to medical decision-making. So in the end, if we prepare to fail, be prepared to fail. We're waging a war, we're in it now against limb loss, and then we just have to use these tools, many of which are in human form today, and that I hope that you'll engage in the next few minutes to get the victory, to get the outcome that's not only satisfactory for us, but satisfactory for the patient. And we're gonna go to our panelists.
Thank you so much, Nicole, Dr. Branning. Just wanted to kind of tie everything together and really leave you with some of those facts. And so I'm going to open up the mics for any questions if somebody has them. Does anybody want to start with questions or comments in there? Yeah, please.
Hi. Is this on?
Yes,
Hi,
and
Jim
what-
Murphy. Just a question for Dr. Jeffries. I think the automation bias is actually much more prevalent and a bigger problem than we think. And I think many decisions are being made on big data, on automation. And the further those people are that make those decisions away from the actual data where it's gathered, the less they have the ability to use their own intuition to seem like this seems right or this doesn't seem right. And I feel like that's a bigger and bigger challenge. And I've been lucky that I've kind of been at both ends, seeing the actual data and then also work where it's collected. And I find it's very challenging to challenge someone and say, this doesn't seem right, especially when they have that data available or from, some kind of generative thing. So my question would be, how do you kind of protect against that, or how do we let, whether our superiors, management, corporations know that this is occurring?
Yeah, it's a good question. Yeah, I think it would depend on the use case, but one thing that I also touched on briefly, which I think is relevant to the question you were asking, is it's important that if people are supposed to be evaluating those outputs, I gave an example of something where the person is just supposed to accept the output as ground truth, like that colon cancer screening thing. It's like, yeah, just trust. They're going to be in a higher risk pool. That's fine. But there are going to be cases where they really are supposed to be thinking about it more carefully. And so, yeah, you really have to think when you're designing the system, do they have the information that they need in order to make that decision? And that information can be a combination of their own expertise, but also can be information that is presented to them along with that output. I think, I mean, one question that the way that you framed that, or you're kind of asking, or you were talking about a situation where people are more removed from, from that process, whatever it is that they're supposed to be evaluating. They're more removed from it, so maybe less capable of making those judgments. And I think that's something that is arguably a little bit easier to act on. The automation bias problem is hard because you want the thing to do a good job, but if it does too good of a job, then you can run into problems when it, in these isolated cases where it doesn't do a good job. But I think you can address that through just thinking more about, like, who are you presenting this to? Do they have the necessary information and expertise to make that judgment? And probably in some cases, they don't.
And what department are you? Yeah, thank you. Thanks. So I really like how we've presented a lot of the information. I do want to get the other question here, but as this individual is going to be asking, I want to act as a little bit of a devil's advocate. We're here as providers, we're inundated, we're trying to learn new tools, we're trying to be more efficient. We want to be able to use AI. So as you're sitting here, I would love to hear what you think some of the biggest hurdles are for us and how maybe administration is carving out some of those tools and time. So we have tools, but do we have the time to be able to use them? So I'm going to just plant that there while we take the next question.
Hey, how's it going? John Lyon, and I'm also from the orthopedic surgery department. My question is, or maybe more of a challenge to either Dr. Levy or Dr. Jeffries. We're sitting in the medical school. Our product is physicians that we're producing out of here. I also have 2 sons that are hoping to become physicians as well. Certainly with the AI and informatics advancements, there can be, at least, I think you guys would agree, there'd be ways or places where either non-physicians, physician extenders, could help in that role of allaying the burden of the shortage of physicians that we're, particularly surgeons, we're producing in the future. Like, can we? This discussion is excellent for a medical school class, but wouldn't we also kind of advise the medical school class, hey, if you all want to do informatics, maybe we can get other people to do that. And the doctors here can become psychiatrists or surgeons, things that require more human or personal touch. The informatics is great. And likewise, if everyone wanted to be a radiologist from the next class, you might say, hey, we don't need 100 radiologists from this next class because we anticipate that although it won't solve every problem, it may solve some problems. So could you guys address the question of physician extenders, some other way to help the informatics come into our physician field?
So what I would start with is the overwhelming majority of our physicians who are doing informatics are only doing that a small fraction of their time while also practicing medicine. And I would, and about that, while it's great to maximize our time with patients, I think that has helped drive some of the burnout. I think as physicians, and now I'm getting way off topic here, but I think as we have become more employees and less, owners of our own practice, if you will, more and more physicians are looking, what else is there to do besides seeing patients all day, every day? And some of them are finding some time in informatics, others go into various other areas. They go into quality improvement, they go into patient safety, they go into some form of leadership. So I think the problem isn't that we're funneling all of these physicians out of patient care as much as physicians are looking for ways to better round out their practice of medicine than they have in the past. Now, how do you address the shortage? They've been talking about the shortage of pathologists now since I started my residency back in the 80s. Well, guess what? Is there a shortage? Well, pathologists have gotten better at doing more work in less time, partly due to all of these tools that we have, the automation, right? Now, some of the AI and machine learning is helping to mitigate this. One example I think of in pathology that most people are not aware of, in an early example of image analysis, most of the negative Pap smears never have human eyes set on them. They are reviewed by machine. 10% are randomly chosen to be reviewed by humans to make sure the model stays on track so we don't have some kind of divergence. But most people don't realize we've been doing it. Now think of the workload that saves. Now look at that and multiply that out across all of the other potential use cases that we can apply technology to focus your work on, we use the phrase at the top of your license, right? Have you focus on the tasks that require your skills and minimize the number of tasks you have to do that could be done by anybody or some sort of technology to supplement it. So I think the physician shortage predicted for a long time, it's hard to say what the reality of it is because they're anticipating what the number of physicians should be, but as I said from my experience in pathology, it never seems to materialize. We just get better at what we do to mitigate most of that shortage. I don't know if you have anything to add,
Thank you.
Morgan or Trang?
That was so good. I'm not going to make it better than that. Let's just go with that.
Thank you.
Well, I think you brought a good point up that we are, we're not training all of these medical students and residents to be, in informatics. It's just one other tool. And I have started to look at it as a tool that is almost humanizing my practice of medicine again. And I say that even though we're using technology, but if I can look at having an extender be artificial intelligence to use a bridge, use ambient conversation, and put it in a form that I can just review quickly and then use my medical knowledge and know what is good and not, but not have to do so many clicks, like we saw that picture that Dr. Levy showed us. I feel like it has given me and my patient back the human touch in there. So when you talk about psychology, psychiatry, our mental health crisis that we have, I feel like being able to use the right tools at the right time, and imagine being in a room with that one-on-one, mental health specialist and having that ambient dictation that doesn't really act as an intruder. Right now, this is the intruder. This is what we're doing. We're trying to capture, and we've all gotten really good at multitasking. I think we need to decrease the amount of multitasking and start focusing on the good medicine and the good patient care, but be able to have that in the background.
I just wanted to say one thing. We think we're good at multitasking.
We're not good. No.
We think we're better than we are.
Well, we start to fall, it's a degradation of sorts that we don't realize, and, the pajama time, the overexertion, the, I call it the shiny object moment where I went in the room, what did I go in there for? And so we're multitasking because we're trying to use everything at full blast, where we need to be able to have artificial intelligence as an extender so that we aren't overtasking. Question?
Hi, I'm Matt. I'm one of the second-year orthopedic residents in the Northeast. Thanks for putting this together, and it's really been educational and eye-opening in many degrees. A question that I have two questions related to the ambient technology that I think are pertinent for discussion purposes. One would be the ambient technology. I assume that it would be capable, and if it's not, it should be in my mind, to essentially take this conversation and produce quantitative data from that, so that it's in a prospective type patient registry / database that is then queryable by us in the future. 10 years from now, then we'll have all these patient visits that are in number format, big data format, as we described. The other question that I have that I think is an important thing for us to consider as a health system that's trying to, progress this topic would be the legal ramifications. We talked about this morning, actually, in a small group, of having the entire visit recorded in a sense and potentially acquirable by in the future. And what does that look like for the physicians that would be utilizing it and the system? And I'm just curious about that type of the framework that surrounds that. And on that point, the inclusion of myself as a learner is what I say in the room where the recording is where the recording is happening, then included in, oh, well, this was said in the patient encounter. It wasn't documented because it was potentially the, student physician or the medical student, what have you. Just interesting things I think that I'm sure are considered, but I'd just be curious to hear your guys' perspective as leadership on that.
As far as extracting structured data from text, foundation models can do that to some extent. Sometimes it can be a struggle to keep them on task, but there are some tricks that people have figured out. There's something called constrained decoding, where you can basically force them to output something in like this exact format, and that can keep them on task a little bit more. I know that Abridge is working on nursing documentation, which really, that's driven by structured inputs. So they're basically, in the course of doing that, they're going to learn more and more about how to do that effectively. And so we don't know their full product roadmap, but I would imagine that, yes, there would be more and more of that kind of like structured data extraction that would be a part of that. Storing the recordings, probably a little bit more complicated. There are definitely like privacy and security issues around that. That's also, the recorded data probably is larger than text data for sure. I don't know that they have any, I haven't heard that they have any plans to do that. I think that gets purged.
Correct.
So, it's a thought, but to some extent, we're kind of at their mercy in terms of like what they decide to implement. I have not heard them moving in that direction. And then I thought there was one more part of that.
Big data.
Essentially how it affects the learners as well.
Oh, how that affects the...
How having the ambient technology would affect us as learners and what we say implementing the note or not.
Yeah, that's a decent question.
Kind of like what we do with simulation, patient simulation, where we use the opportunity in a simulation lab to watch you speak to a patient, and maybe there'll be an opportunity with the pilot, 2.0, 3.0, to maybe save some with permission, consent from patients to be a teaching pearl for learners. I don't know which direction, but you bring up a good point, because I think, one, we need to be inclusive of our learners. Right now, one of the points with ambient, the ambient technology, specifically Abridge, is that it does not incorporate our extenders and our learners in being able to use the tool right now. But that is after the pilot, and we have the licenses that are broadened for a lot of providers. So I think there's opportunity. So keep thinking like that, because those questions are what, drive the machine to get us to the needs that we have.
Hey, Matt, I think, were you asking if by virtue of recording, you're legally liable for stuff? I think that Matt's asking about his liability because everything is recorded. And I think that that's more the basis of it, not how it's incorporated, but essentially having all of these transcripts of conversations and what are the legal implications for the residents. Does anybody have anything to comment about on that?
So what I would say about it is Abridge does not retain either the recording or the transcript beyond the making of the note. It's all destroyed. The interesting question in my mind is, will the legal system force that material to be retained as evidence? And what drives that for me is over the past year or so, there's been a growing movement within medical malpractice to literally make the EHR one of the witnesses. where they're looking for experts to come in and say, well, the doctor said I placed the order at 3:05, but the log says you did it at 4:05, right?
Yeah.
So, yes, there is clearly a potential risk. But I would say right now, just your being in the room as a resident or a medical student, you get put on the list.
Yeah.
Because everybody, I mean, if you're familiar with medical malpractice at all, they do a shotgun approach and they put every possible name that they can find in there. And it's just a legal mechanism that they use.
It's actually legal malpractice if they don't name everyone who's responsible up front. I have a friend who's a plaintiff's attorney who explained this concept to me. It's like, we have to name everybody who could possibly be involved because we can't pull people into the suit later on.
Yeah, I just think it's a really interesting aspect of like progressing forward with this like really useful technology. It's just something to consider as a system, and as you guys in charge, I just appreciate that you recognize that.
We are thinking about that.
Good point.
And it's a great question. We'll see. We will see what that answer becomes as time goes forward.
Thank you all for your comments.
Thank you. Next question.
Hi, I'm Stephanie. I am a PGY1 in orthopedics at Danville. My question has to do with, I should start off saying, I use AI for almost everything in my personal life. I love AI, but I kind of hesitate to use it in the clinical space. And I say that because I know AI, you have to use algorithms in order to create whatever system or product it is. But people are creating these algorithms, so from at least what I've seen in some articles, it introduces some bias. And I think the one I think about is the MIT student who saw bias with facial recognition for different races. So with that being said, I know we kind of talked about tailoring care based off of different demographics. My question is, and I guess I want to hear your thoughts on how do you think we can mitigate some of the biases that AI will introduce into decision-making or assessment of patients, and then if there are any safeguards in place right now for that?
Yeah, it's a great question, and it's definitely a very challenging problem. So you mentioned the algorithms are made by people, but really it's not. Nobody's designing that stuff to be part of the system. The issue is that or a big issue is that there are just patterns in the data that may be based on, in some cases, it's based on sort of historical unfairness, some other kind of systemic unfairness, and it's captured in the data, and then that can translate into what's called automated discrimination, where now you have a system that is making predictions based on these historical data. There was a case where Optum had developed a model that basically, so it's for patients who are going to be utilizing the system a lot in the future. They can have these sort of high cost interventions that health coaches and things come and work with them. So basically they don't wind up with that very expensive ER visit or hospital admission. So a bunch of researchers, and this is probably, I forget how many years ago this was, but they looked at this algorithm that Optum had built, or this model that Optum had built, and that was being used in a bunch of places. And they found out that when they used a separate measure of how sick patients were, which is basically, I think they used the number of chronic conditions, and they plotted that, and they looked at, okay, here's the risk score assigned by the model, and here is the risk score according to how many chronic conditions they had. Black patients were systematically less likely to be assigned a high risk by the model than white patients. And it was unclear exactly why that was. Some of that might have been just, they may be utilizing the system less. That model is actually okay if what you're trying to predict is cost. But you have to be very much aware of, there's this pattern in the data of they're tending to get less care. So when you start using it when you change that slightly to mean they need less care, now that becomes invalid. And so now it's systematically not providing care to these people that should be getting care. So it's a big problem. How do we address this? So we actually have, as part of our intake process for new AI projects, and also just for vendor intake, we have a group that basically looks at what the what the system is that is being requested, or that has been built, like what it is that we want to use. And essentially we look and we try to assign a level of risk to that. And if we think that there is a significant risk for bias, then we will incorporate that into the requirements for what has to be done in order for that to go live. So, if it's something, there are certain systems, and we don't need to go into all of the details, but there are certain systems where it's like, yeah, this probably is not going to result in any kind of discrimination. It's fine. And then there are other systems where it's like, yeah, this absolutely could affect people differently. This could exacerbate existing health disparities. And so we need to make sure that the model is tested for bias, but we also need to think about the system as a whole and how it may be more easily accessed by certain groups of people than others. So I will say, it takes a lot of work to do that. Like, that's one of the biggest problems, is that people want the thing that they want now, and we have to kind of push back and say, like, we kind of need to do this more detailed assessment, and it takes a lot of work, and we're sort of understaffed currently to do that. So we're looking to get more and more people involved in that. But yeah, it's definitely top of mind for us.
And I think that's exacerbated by the mindset of the technology experts who want to, move fast and break things. So along that way, you end up going down a lot of pathways maybe we are better not going down. I would say adds to that.
Thank you.
Thanks.
So it goes back to also recruiting for, user experience, being able to have a wider playing field of people who are giving us the data, helping, and, looking at it through the lens that you just brought up. I'm sure there are other lenses that we could, but we definitely are starting with the foundation. And I'm going to come back to the question that I volleyed to you. So as far as, help or hurdles as we kind of go forward with informatics and starting to implement it, whether it be through the residency or our own practices. How much of a connection or disconnect do you think there is from, an administrative lens and a clinical lens? I'm going to start with Dr. Levy.
Thank you. I think, like I said in my presentation, the gap we really experience right now starts out with lack of knowledge. None of us have a lot of knowledge about this. A lot of us don't have much experience with it. It makes us very uncomfortable to deal with. And that opens the door to a lot of things happening in ways perhaps we would prefer they not to happen, right? Others are making decisions. And that's why I think it's really important for all of us to have some level of knowledge of this, so we can apply our professional experience, our clinical judgment into these decisions of what's being implemented, how it's being implemented, how we're going to use it, and what we're using it for. And so, and maybe I'm seeing it through my bias, right, because I'm deeply involved with this education, but I think one of the foundational pieces is providing knowledge and skills to people so they're comfortable using these tools and can then apply their other expertise to this problem. There are other dimensions of it, I'm sure. Maybe someone else on the panel can help enlighten that.
No, that's great. I mean, I've seen it where I take the messages we get from Epic, where they say, if you have any thoughts or improvement or suggestions, please send them in. When I would see that, I thought, is it just going somewhere nebulous? And now I know kind of, it's like the Oz behind the curtain. I know that there are people who are looking and who are wanting to implement these, even if it's on a microcosm of how it affects my daily, everyday practice. So I know that it's a convoluted question, and I definitely know it's a loaded question, but I think that starting here in an educational arena, and then with providers who are seasoned or just starting, and different specialties, it's a good way to start. It's a good way to start and really kind of peel back those layers. I don't know if there are other questions that we have there. We will be hanging around after. I do want to comment as I start the closing that this is probably one of the highest attendance online streaming as well as here, and bringing people from all different areas. And so I've gotten messages throughout the day before this started, is this going to be recorded? Is it going to be accessible? And so this is really specific for our donor. Arturo, just to know that this is the legacy that we are leaving from an educational platform. We want this to be accessible, not just now, not just today, but for the future. So when residents start and they want to learn different things, there'll be a library. It's the Parenti Library legacy on, education from all different things. So, I was really happy to hear the excitement behind that. So,
Kathy, let me just say for a minute, I'm truly honored and humbled that this interaction with a patient of mine nearly 20 years ago has resulted in such a high-level meeting with students and residents and individuals who have a knowledge of a subject that obviously wasn't even conceived during the presence of my practice. And maybe I thank God for that, I'm not sure. I remember the paper chart when I used to write notes in the margins. Patient likes fly fishing, so when he would come in next time, I would mention that to him, and it would bring such a joy to someone's face that, boy, he knows me. How does he know I like fly fishing? How does he know I'm a Yankee fan? And there's something that I hope is not going to be lost with artificial intelligence and stuff like that, to know your patient, to really feel for him, have an empathy, and that we will still have that bond with the patient that you get to know when you have a cup of coffee with them, or you just mention his family, et cetera. So Arturo and I have become incredibly close friends. I hope Nina is doing well and with her illness, and they couldn't be here today. But their donation, their enthusiasm about scholarship, about education is just immense. And for him being a benefactor for this in my behalf is certainly an honor that is just very close to me, and I feel humbled by it. So thank you for joining us today. Your presentations were awesome. And thank the audience, and thank Dr. Zinser and certainly Dr. Sook for putting this on every year. I'm very humbled. Thank you all.
I want to share exactly what you're saying. We don't ever want humanity to get lost, or the dignity of a patient and a doctor relationship. And to your credit with knowing they're a Yankees fan or knowing they just had their first grandchild, AI does have the Post-its that I use all the time in the top right corner, and it's really very personal, but I share it with my team, and my team can't see my Post-its unless they're over my shoulder, but they've started to really incorporate that so it becomes a culture, right? We talked about culture and how as we get into this new wave, it doesn't mean we lose our humanity. I think we gain back a lot of it, but we also incorporate this as another tool to still build those connections. So, wow, ding, that was my. So I want to take, I don't know what that is. Kara? So.
Time's up.
I'm going to just hit that. We recognized systemic capillary leak syndrome and made it a lower limb salvage awareness day. And so we recognized this for Arturo, and we presented him with this. We also recognized a certificate of commendation for Dr. Parenti, and it was for more than 30 plus years, give or take, right? For Dr. Parenti's tireless passion for his work has given not only renewed hope, but a new lease on life to many. So when October 7th comes around, it is really, what did you get text? The Dr. Parenti Day. Dr. Parenti's professionalism. All over the world. But it's for professional accomplishments rooted in compassion for his patients and their caregivers. His unassuming manner belies the consummate expertise which has saved the lives and limbs of hundreds of patients suffering debilitating disease. He has earned the respect of patients and peers alike. His professional reputation surpasses the boundaries of Montour County, with many patients traveling from all parts of the Commonwealth and throughout the United States seeking his help. For his many years of selfless service, we, the commissioners of Montour County, as he stated, do recognize and thank Dr. John Parenti the 7th day of October 2022, which for every day in perpetuity, October 7th will be, to me, Dr. Parenti Day.
So I just wanted to close as well. First of all, let's give a round of applause to the but I hope Arturo and Nina can still hear us even though the mics are off. And of course, we want to thank Arturo and Nina for their constant dedication, over a decade of support for our department and much consultants too. It's really, for us at Geisinger, certainly very welcome when we find somebody who's that dedicated to the work that they're doing. I also want to comment that rarely do you see a panel of 8 people or 7 or 8 people kind of get along as well on a stage, and so I want to congratulate the panel for all that they've done as well. I would just say that part of what we do at MSK is saving lives, not in the sense of life and death, but certainly creating mobility and opportunity for people to live productive lives. We're all about mobility, we're about saving limbs, we're about making people's quality of life better, and I think that's why we all do it. And I'm really proud of everybody who's here and took the day to come in on a Friday and celebrate this day with us, and particularly with John Parenti, who, you know, I think he wanted to leave Florida about this time to come visit us, but we're really glad that he came up and decided to join us as well. Before we end, I just say that you know, part of being part of the Parenti Conference is also being inducted as a member of the MSK family. So all of you, I hope you brought these because you know what it means, all of you. And so I just want to present to our 3 keynote speakers here today. First, this is a challenge coin from orthopedics. So we'll pass the question to Andy. I'll pass these to you. And for those of you who are not aware, MSK has a challenge coin which was built out of our, built largely out of a military tradition, where members of your family or your troop are given a coin which represents who you are and where you come from and why you have some sense of connection to the people around you. It's turned into not just a loyalty thing, but it's also a drinking game, as you all know. So when you see somebody from your platoon or from your unit and you present your coin and they don't have theirs, see all the scared faces? Are they buying? And they don't. All right. But today is a good day for all of us to drink on the residence, I think. But I'll leave it at that. And again, final words is just to say thank you for everybody and all of our work. You know, we don't do it very often when we get together, but I always treasure these moments because it's great to see everybody across our system get together. So thank you very much, and Katja, thank you.